Welcome everyone to the November Integrated Care Board meeting for Cornwall and the Isles of Scilly. Gosh, these meetings must be really entertaining to see so many colleagues wanting to come in person as well. It's fantastic. We do have some colleagues on the call as well, and that's absolutely fine. We understand. So welcome to everybody. One particular new face I'd like to welcome, not formally, but just as a guest to the public board meeting, is the designate chair for Royal Cornwall Hospital, David Allen. Welcome to you. And I think you formally start in January, January the 7th. Okay, thank you very much. I don't think there's anybody else I ought to introduce. No. In terms of apologies, looks like a full house. I know that we've got Nick coming in and out on the screen. He goes on, he's apologised in part for today.
Apologies from Alan Gorman.
Yeah.
Thank you very much. So let's move to the declarations of interest. Any issues there? No? Happy for me to take that? Very good. So we'll take that as done. Let's move to the approval of the minutes of the 10th of October. Are you happy for me to sign them as an accurate record of the meeting? Yeah.
Can I just be added to the attendee list, please? I've just been missed off.
Okay.
Thank you.
Thank you. Very good.
Likewise the same.
And, okay. In which case, with those two amendments, I will make that. I'll sign those. Then we've got two public questions. So I'm going to go to Simon first. Would you mind dealing with your question first?
Thank you. This is just in response to a question about the high level of spend that's outstanding on backlog maintenance and buildings that have been raised at national NHS level with multiple billions, I think, being highlighted as a national number. We were asked the question from the public about what the position was in Cornwall. And so what I want to be able to share is the results of the survey work, infrastructure survey work that was undertaken about 2 months ago. And on the back of that, we're not able to present a financial number in terms of what we want to target and the value of investment on backlog maintenance and particular buildings that await further improvement and targeted improvement. But we will be clear by the time we get to January board. So I was going to give a formal update from my estates colleague, having done that work at the January board, which will highlight the areas we're targeting in our estate to bring backlog maintenance up to date and invest in the areas that we want to target. And that was it. Thank you.
Okay, thank you very much. Then the second question, I think, Chris, are you dealing with that one?
I am, Chair. The questions around primary care hubs. What engagement will there be with patients in surgeries where the primary care hub is difficult to reach by reasons of distance or transport compared to patients' own surgery? Will patients need to access same-day care but unable to reach primary care still be able to go to their own GP surgery? And will funding recognise this need? The answer is there's currently 11 primary care hubs across Cornwall that are open at the same hours as general practice. There's ongoing discussions led by the GP Collaborative about whether these hubs provide sufficient access for a population, but they're in similar locations to our out-of-hours GP locations that have been chosen to ensure most people can access a hub within 30 minutes. And if the patient is not able to travel to the hub, they are still able to be seen at their own GP practice. All GP practices should be able to access some appointments at the hubs for people that have an urgent on-the-day need and who are able to travel to the hub location. The appointment should be for those who do not require continuity of care. All appointments are triaged before asking the patient to go to the hub rather than be seen at their own practice, and the practice should have a conversation with the patient for that. The funding of the hubs is in addition to core GP services, so GP practice continue to be funded in the usual way, i.e. there's no loss of funding as a result of these hubs.
Thank you very much. Happy with that? Okay, so I'll move on to the rest part of the agenda. But now, Terry, just before we bring in this part of the agenda, I've just got to sort of set the scene for maybe how this morning might go. So yesterday, there was quite an interesting day yesterday. There was some reporting in the marketplace on a speech made by the chief exec of the NHS. And I think it's probably fair to say that somewhere between, this is my phrase, never let the facts get in the way of a good story, okay? Between what's been reported compared to what actually was said, we wait to actually get more of the facts of what was said on that. Also, the Secretary of State actually made a speech yesterday, and as part of that, for clarification and for real clarity for everybody around the country, what's been organised is that at 10:30, we're going to, Kate and I, and probably Steve, Debbie, Margaret and Mary will have to step out. So therefore, Sanj, you'll be chairing in my absence, and Susan, wherever you are, you'll be standing in on behalf of Kate. We will be stepping out at 10:30 for half an hour to actually hear a briefing directly from the NHS Chief Executive and from the Secretary of State. And then we'll come back, hopefully in half an hour's time, and we will then continue on. Okay? So I apologise if the agenda has changed. I hadn't quite foreseen that when diarising this and planning it out earlier on. Let's move back into the agenda as best we can, watching the clock. We'll need to leave at 25 past to go out and log on. So Sanj, if we'll be ready at 25 past, please, just to pick up from wherever we're at. So Terry, welcome in person, by the way, for the first time. Update on the action log, please.
Yes, so colleagues will note there's a large number of actions which have been marked green and we're proposing to close because they have now been actioned or followed up. So I know there was a request at the last board meeting to tidy up the action log, so we've closed a fair good chunk of these. So obviously if board colleagues have got any questions on the proposed close actions, then happy to take those, or colleagues would be equally. There are a number of actions which are still open, which I wasn't proposing to go through at this point, but just to follow up with the individuals and bring back further action updates to the next meeting. There's nothing urgent that I need to bring to the board's attention.
Just to clarify that for the June updates, the update relating to item 10 actually sits as the update for item 9. It's just been put in the wrong line. And Kelvin has offered a briefing on the work around digital inclusion to a future board development session. Perhaps it fits with the digital session in the new year. So if we planned that in, perhaps we could close that action down.
Yeah, are you happy with that? Yeah. Very happy. Thank you, Tracy, for that. Happy with that? Yeah. Very good. Anything else? Okay, so we'll move on to vignettes. Now, normally our vignettes are patient and staff very focused on things. We've learned a lot from our vignettes over the last couple of years while we've been doing them. They've had huge impacts on us investing as a group on things like the Brazilian model, the community health workers. I think we've got 45 of those now on the back of that. X-ray cars and that kind of thing. Astonishing amount of work. But once it gets lit and shone in our group, how we can actually see the value in these things and then understand what's going on and move forward and grow some of these areas and invest in them. But this time round, it was an opportunity to actually, assume you've all seen the vignettes and been through them. I certainly have. We've actually had some of the key chief executives around the table actually give their thoughts on the commissioning intentions. So I'm just going to really reach out to that group who did the videos this time round and see whether, in fact, you would actually like to add any commentary. And I'm just going to go around each of you to see whether there's anything that you would like to add to that. So maybe, Emma, would you like to maybe reflect on what you said and any contribution that you made?
It was actually a really useful.
So can you lean forward?
I thought it was a really useful opportunity to reflect as we go along, and whether or not we publish it as a vignette next time around, I actually think it's quite a useful way of just having a bit of a stock take as we move through the next sort of 3 or 4 months into the end of the financial year. So I really welcomed the opportunity to share what we were doing. I suppose the question is, what do we collectively do next with them, and do we do them again? Because I think even if we don't necessarily publish them as an internal communication tool, I think they're really helpful.
Yeah, I think the intention is to make good use of them. I think we have quite a few plans as part of our tenure engagement to use them, but also we thought we'd use them this time instead of we usually do an interview with a board member, that we would publish these instead. Yeah,
I think it's important, if it's all right with everyone, that we publish those. Okay. Anything that you wanted to ask Emma at all, based on that? No? Smitesh, you were on the vignettes. What would you like to add?
Thank you, Chair. I think it was really useful to see everybody else's take on things like the commissioning intentions. I found it very useful from that perspective. I think, as Emma said, I think it'd be good to continue to use those as a stock take, because sometimes the thought process behind where we go with commissioning intentions changes, and I think it's important for the board to be able to be aware of that.
Thank you. Happy with that?
Yeah, very happy. And in terms of where we go with it, the intention is for the December board meeting that we follow them up with vignettes with clinicians who will be taking forward the commissioning intentions and describing how that model of care will work.
Excellent idea. Thank you. So let's now go to Debbie on the screen.
Yes, thank you. Well, I really appreciated being able to talk about mental health, and particularly our ambition and commitment to driving down the number of out-of-area placements. I think it was important to be able to highlight the impact an out-of-area placement has on people, and our collective determination to resolve that, and to also talk about some of our out-of-hospital opportunities, and also what the initiatives are that we've already set up. I thought that Lucy and Matt, I think it was, who was driving the camera, did a good job in terms of getting the balance between all of us. And I felt that they told a very compelling story. So I'm grateful for the opportunity and agree with the comments that have been made about next steps, particularly Tracy's. Let's get some clinicians to talk about some specific pieces of work that they're leading clinically.
Thank you. And just to build on that, certainly from my perspective, sometimes it's easy to see a lens through a sort of microscope kind of way, or a particular view. When you actually saw each of them actually chatting, giving their perspective, so the whole is more than the sum of the parts, you suddenly, from a helicopter view, added the bits up like a jigsaw. Really, everyone's aligned and coming together. So thank you for making that observation, Debbie. So let's go to Steve. Steve, what would you like to reflect on from your vignette?
Well, I would have reflected the point you just made. I think when we see all of the 5 videos together, it does give that overview that we've not necessarily had before. So I really hope that's been accessible for board members, for colleagues who work across health and care, and for patients and community members. I thought that's probably the most powerful part, seeing all 5 together. For the 2 areas that I covered, urgent and emergency and intermediate care, hopefully what came across is the determination we have in Cornwall and Isles of Scilly to enable care to be received in the community where that's appropriate. A significant shift from acute to community to avoid unnecessary conveyances to emergency department, to avoid unnecessary admissions. We know that has a significant benefit from an acute hospital perspective, but probably even more importantly, that has a significant benefit for individual patients and the care that they provide. So hopefully the ambition there was conveyed. And from a planned care perspective, the determination we have to reduce waiting times and improve access into our essential planned care services is at the heart of that part of the commissioning intentions. So hopefully they were the things that came across in that vignette.
Thank you ever so much. Finally, Kate.
So I think the fact that we've all made our statements around what the commissioning intentions mean to us and the specific sectors that we work in, it's a really strong commitment to our population around what we intend to do next year, how we're going to reshape our services around the people we serve, and start to get into that very place-based, localised, personalised care that we've offered. So I think they're a great starting point for us all to hold ourselves to account for delivering. And as a promise to our community, I think it's great. If we still did paper, you know, in the old days when we had publications that were done in paper and we gave them out, it would be really nice if the wrapper for our plan for submission had all of those vignettes on it, because what it does is it shows the how we have come together as a single leadership team for our county.
Very much a unitary perspective, and it really felt like that, which is why I'm sorry if I stole your thunder, Steve, in terms of summarising that. Okay, but pass on our thanks to Lucy and the team. Yet more great work. Thank you ever so much. So as I said in my intro, as we've got Kay and I've got to step out in 10 minutes, we're going to skip my paper and the chief execs, and we're going to go to the updates of the chairs, and we'll come back to item 3 and item 4 once we come back in the room. So I'll kick off by going around the committee chairs first of all. So Sally, I'm going to start with yourself. Any update from your seat? Yes, Ange, any update?
Yeah. Only one update, which was regarding what we're going to focus on in December, and the recognition that what we have seen at committee so far on channel shift is still broad in its outline, and that we're really expecting, particularly as the ICB paper as well, this month doesn't go all that way, but in December, much more definitive intentions around commissioning and channel shift next year. But also that the recommendation of the committee is that we do focus on UEC as part of discussions board to board and at ICB in December, given the urgency and the current situation reported in FPCC, which is, without going to details, you can see in the integrated performance report, quite alarming in terms of direction of travel, quite a sharp deterioration. And so we recommend that we focus on this in December.
Any thoughts on that?
I think it's a really good idea. So I'm heading into the most difficult part of winter, and we know that January for many of our residents is a difficult time to get in and out of hospital. So I think it's a great idea.
Thanks, Ange. So let's go to Neil on the screen, please.
Thanks, Chair. Hopefully, the only highlight I wanted to bring out of the Quality Committee report, this being one of the first ones that focused on primary care and equity, is that the committee felt there was a need for more assurance in terms of the primary care strategy around patient engagement, health inequalities and sufficient capacity within primary care. The committee felt that further work to the key approaches needed within the commissioning intentions of the board is needed, especially regarding primary care hubs, integrated neighbourhood teams and MDTs based in communities. I'm obviously hopeful that some of what we're going to hear today, particularly from the GP Collaborative, will help assure the board as to the direction of travel here, and look forward into December for more clarity on the how we're going to do this.
Very much. Thank you very much, everyone. So let's go to Martin.
No meeting this month.
Lovely. Tan's not here and Nick is not on the screen. I guess the one question I've got, if Nick was here, is there was a delay in the SEEK discussion. Have we got a new date for that to actually happen? Do we know?
I don't think we have. I think Nick was still liaising and speaking with chairs across the providers.
If we can make sure that date is put back in the diary.
Yep.
Sorry.
Bill and Miriam and Nick had a meeting last, I think it was last week or earlier this week, to talk about the way forward. I think I think they've come, they had a discussion, and I think there will be a subsequent meeting. But
very good. Okay, so if we could just catch up on that, and if you could engage in that, I'd be grateful. So you're content with it as well. Okay, so that's the committee chairs. Partner members, we're going to start with Emma.
We have got to raise a significant concern as a result of the budget the week before last on the cost pressures within our sector. We've done nationally some
The Chancellor's budget.
The Chancellor's budget, sorry, yes, just to be clear. The national expectation and calculation is approximately £1.4 billion additional cost pressure, and we've done some very rough estimations for Cornwall. That's looking like somewhere in the region of £9 million of additional cost pressure. Now, clearly, our formally commissioned services have no inbuilt ability to uplift. There is some ability to do that within charitable and grant-funded opportunities, but this is a significant risk, I think, for our sector and for our board, because we will see, undoubtedly, charities going to the wall as a result of this. We're currently doing a piece of work with our sector to understand what the significant impacts will be, but I do want to raise this as a significant issue for the board, and I do think we should consider putting this on our risk register, given the amount of discussion we've had about resources and future commissioning of the sector.
And just to clarify, you're talking about the national insurance on employer
and the living wage.
The living wage. So both elements together are worth more than 9 million. I'll go to Chris and then Mary.
Just obviously link with that. It's been raised very clearly by our general practice colleagues as well. And I'll give you an example of a a practice, say, of 30,000, the impact on the increase in national insurance contributions will cost that practice £160,000. So bearing in mind collective action, and this is something that I think we just have to be aware of.
Thank you. So we've got the voluntary sector, we've got general practice. Mary?
Thank you, John, and thanks, Emma. I was just wondering what opportunity, if any, there might be for a more strategic approach to what happens, because the difficulty, as I think I'm understanding from you, is it's likely that people will just go out of business and not be able to go on. But could we get any kind of more strategic approach to that? My first point, John. And my second point is that this also has a significant effect on people's personal budget, disabled and older people's personal budgets, which will have a significant implication for the council.
Did you want to respond to that before I move on?
I think that's a great idea. I think there's the potential for 3 impacts here. One is that they will reduce staffing. 2 is that they will reduce the level of service that they're able to offer to people and communities. And 3 is that some will go out of business. So I think once we know a little bit more about where we think those impacts and the magnitude of those impacts, absolutely. But I think we need to have a strategic conversation, and we will be writing to our MPs on behalf of the sector to raise our concerns, as well as supporting a national open letter to the Chancellor calling for exemptions for the sector.
Okay. Mary?
To reinforce what everyone else is saying, that the impact on the care sector is phenomenal. My own services alone, it's going to cost us between £500,000 and £600,000 when you factor in the. I'm talking about 140 beds, so that's 220 staff. If you're just limited to the 615 that they're talking about per staff member, but then add in the uplift in the national minimum wage, the increase in employers' national insurance contribution that will create from April, the day one SSP, it comes out at something phenomenal. And as you said, Emma, the statutory services haven't got the resources to uplift the fees accordingly. It's about £3,500 per bed per year in my service.
Emma?
Yeah, thanks, Chair. Just to add a practical note, the LMC with a number of practices met with Noah Law MP last Friday and put this point, not just for us, but for community pharmacy colleagues, for the whole of the healthcare landscape. I think his plan, which we'll be holding him to, is to go away with his other 5 colleagues and to bring together some form of joint communication, which I've strongly suggested is shared before it's aired, as it were. So we'll keep you posted.
Thank you. So what we're going to, I'm going to hand over to you in a second, Sanj, but can I just make this observation? We're going to go Kate, Steve, Tracy, and then we may have to step out before we get to that sequence, but I'd like you to think, Sanj, what, as a unitary board, taking Emma's point about the risk register, what do we want to do about this information as a result of this? Do we want to write to the Chancellor or to make the point? How do we escalate the implications on our health and care system? Because it is touching on care homes, general practice, third sector. I'm sure there are other unrelated services that haven't thought through here that are going to have an impact on it. So, Kate, you say what you need to say, and then you and I need to go.
So, as a strategic commissioner, we've got responsibility for everything in Cornwall and the Isles of Scilly, not just the statutory services that we purchase. So yes, we should put it on our risk register, but we should also log it as a financial implication going into 25-26. Because if general practice falls over, the care sector falls over, and the voluntary sector falls over, the burden on our statutory services will be too great to bear. So we just need to map it through, Simon, as part of the thinking that goes through our financial planning.
Okay.
Just briefly add to that.
We're going to go. Sorry, Sanj, over to you, Sanj.
Strongly support the comments made so far. There is also the likely impact from a supply chain perspective on NHS provider organisations. So whilst that won't be as immediate as the impact that Emma and Mary have described, that could be a significant impact into the future year going forward. So in terms of a system risk, I think it'd be useful to capture the totality of the implications.
Steve, we'll just let people step out. We'll carry on this discussion. Who was next? Was it Tracy? Yeah.
Yeah, I just wanted to make a slightly broader point. At the Cornwall Executive Group meeting a couple of weeks ago, we were hearing from all of the sectors, and of course SME businesses are also significantly impacted, and for some will mean that they are unable to continue. And we know from the report from Rachel today the impact on work and health. And there was a real encouragement for public sector organisations to think about how they use their roles as anchor organisations and their purchasing power and their influence to buy local and support those organisations at a time when they're going to be struggling considerably. So I think the impacts are much wider than just in terms of the direct things we have influence over, but the impact for people who might lose their jobs in other sectors as well.
Yeah. Smitesh.
Yeah, sorry, thanks, Chair. I just wanted to highlight as well, obviously, our pharmacy and dentistry colleagues will be affected by the same uplift, and probably compounded by the fact it manifesting in the NPA deciding to potentially take industrial action, which may mean a loss of significant services from pharmacies such as emergency contraception and same day care of things like blood pressure, etc. So a massive impact for them.
Yeah, I think that's already underway, hence why Nick's not here. He's doing interviews around that at the national level. So it is an issue. I think we've heard from Kate that we need to have something on paper around the implications across all of these channels: third sector, pharmacy, dentistry, adult social care, and also therefore the knock-on impact on the NHS, which is inevitable. The fact that the NHS is exempt from this doesn't mean that the impact on the ecosystem won't impact us. I would go further to suggest, and perhaps we can discuss this, whether writing to the government is sensible. I know there's mixed views in government, and that the Treasury in particular has a certain position on this that may be different to health and care and others. And so we may have to consider also that on behalf of the ICB, but I think it's probably worth having that discussion when everyone returns to the room on that. Does anyone else want to add anything else on this point?
Just quickly on the council's position and the relationship in raising this as an impact to the sector, particularly social care and all the providers and suppliers that have to pay that. That will be discussed through our cabinet and leader of the council with local MPs, and then petitions through their links into government. Just to sort of also reiterate that that's a process that will be going on through Cornwall Council. Yeah,
but effectively it feels like we're all singing the same tune, right? Nobody actually thinks this is in any way good for us, or that we won't all be impacted on this, whether we're directly or not. Tracy?
Yeah, I guess we ought to slightly separate the financial implications from the decision to increase the living wage, which we all know is a good thing for people and their health. It's the financial implications of that being unfunded that is the issue. But I think we should probably, as a board, recognise that is an important cushion for people in terms of health inequalities and so on.
Yeah, absolutely. I think any sort of intervention we make has to be based around the financial implications for the integrated care board and the health system here. So, yeah, I think broader points around increasing living wage are well taken as beneficial for many. Okay. Are we happy on this one? We're still in partner updates because I don't think we've had everyone, but we've also lost key partners as well. Is there anyone remaining who had an update? Rachel, I'm going to come on to you also for the public health report, but do you want to do an update separate to the public?
Yeah, this is on behalf of Ali and the council on the budget.
Yeah.
So just a short sort of update, and the paper's in the pack, which is a sort of a shortened version of the full cabinet report. But obviously, Cornwall Council is required to set its budget, and the draft budget was considered by cabinet yesterday and approved, which then sets a balanced budget for 25-26, and then goes out to consultation with the public from the 15th of November to the 5th of January. So there's a sort of tried and tested route of consultation through the website, which obviously the members can get full information. But essentially, that was to close a £48 million gap in the budget based on what was obviously
forecasts in terms of increase in demand and cost of services due to sort of inflation and wage pressures. So there's a public dashboard that is part of that, which you know, sort of highlights and sort of summarises what are the actual interventions and plans for each of those savings. So it's transparent and there for you to dig into and the public, and feed that back in the timescale. I mean, quick headlines that the savings are delivered through increases in fees and charges, through reduction in workforce costs, and reducing some of the levels of services. You know, that's what the savings are predicated on. Council tax will go up by the maximum. That will include the adult social care precept to the maximum. But, you know, clearly the 3.2% sort of settlement for core local authority government spending will need to sort of mop up all of those inflationary costs as well, and the NI contributions we've just mentioned are the sort of uncertainty. But I think crucially there's a commitment to fair pay for frontline social care workers of up to £15, and that will cost £54 million if that was to be implemented. So there's a lot of uncertainty about how that's going to be funded as well. But lots in that report, so hopefully it gives you a summary of the decisions that are being made within the council. And I think, as the chairs and the chief exec's report earlier, that does have implications obviously for the whole of the system in terms of pressures that we all share between us.
Martin, thank you.
I suppose just to sort of second that, so I did click through and look at the savings plans, and on the one hand, you know, I'm always very impressed in how local government does savings plans slightly better than NHS, since they are already laid out very clearly and costed very appropriately, and no doubt will be delivered. But I did look through and think, wow, there are some things in here that probably will have an unfortunate effect on healthcare, and I suppose, you know, inevitably it's the sort of longer term interventions, some of the public healthy stuff that, you know, sometimes does take a bit of a battering, as well as in fact some of the actual services. So had you not mentioned it, I was going to raise, Rachel, that you know, we do need to take account some of those changes, I think, as the NHS as well.
Thanks. Any other interventions from ICB participants or updates? No? Okay, thank you. Rachel, if that's all right, can we come back to you now on the public health report? We're jumping ahead, obviously, because Kate and John will come back and do their updates when they're back.
Absolutely. Lovely. Thank you. So I'm delighted to be able to share with the ICB the Director of Public Health Annual Report. Last year, I brought the health inequalities outline, which I think was a sort of very comprehensive report, sort of showing some of the drivers of inequalities. One of those is access to work and the income that comes from work, which drives, you know, key outcomes in terms of health and well-being. If we don't have enough basic resources to live, and the security and the sort of income to do that, it has a profound effect on people's health and well-being. We know unemployed people have poorer outcomes, have shorter lives, and higher risk of things like suicide and other drivers of premature death. So it's really important topic. That's why it's been chosen for this year's Director of Public Health Annual Report. I hope the report sort of goes through and explains some of the reasons why that health and work have a crucial sort of interplay. There's some sort of key issues for Cornwall, which I think I've highlighted within the report, that are very specific, and we have a higher rate of economically inactive people in Cornwall than some other parts of the country. In Cornwall, about 22% of our working age population are not working, and that's for a variety of reasons. But the larger part of that is due to long-term sick and disability. And I think this is something that is obviously being highlighted by the government as a key area of focus with their Getting Britain Working approach. And it's been very topical over the last few years. And certainly in Cornwall Council, this was a report that I wanted to be able to use to work together with our economic growth team to influence the growth strategy, where we're looking at, productivity and growth. Are we looking at supporting the people that are not within the job market and are experiencing inequality in access to to be part of that job market and employment. So this report was able to go alongside the good growth strategy, so that we have an approach that's across economic development, looking at inclusion, looking at supporting people, the reasons that people are not in work. One of the things the report also sort of, I think, highlights well are the two sort of key drivers of the reasons people aren't in work in Cornwall, and being mental health problems and work-related stress, but also musculoskeletal conditions, so all the sort of joint, bone, neck pain, back pain reasons, and that's something that has been consistent throughout the last sort of few decades, really. And I hope this report highlights that there are things that we can do to support people back into work. There's some good evidence-based interventions, including individual placement support and the sort of work that the European Social Fund would support people back into work, and that's been at risk recently with the reduction in the Shared Prosperity Fund. But the benefits of being in work, I think, were described by some people in the report in their own words, around feeling valued, having a purpose, and obviously the benefit of having an income, but being included in the population that are working, the opportunities that brings as well. One of our really, I think, shocking statistics is around the inclusion of people with a learning disability in paid employment. We only have 3% of our population with a learning disability who are supported, who are in paid employment. And again, for people with a mental health problem, it's similarly low. With a severe and enduring mental health problem, it is similarly low. So I think there's a lot of drivers in Cornwall that mean that we have a larger economically inactive population. It isn't good for people's health, and it isn't good for the economy. And when we talk here about productivity, there's a really clear connection between our workforce and our available workforce and the health of the population. So there's a lot of complexity in the subject, but I hope the report sort of shines a bit of a light about the importance of our joint working, both in creating a good economy that's inclusive, that it is a good growth economy, so it's not just the low quality jobs. We're talking about developing, training and skilling people up, and that we as a system have a contribution to make, particularly through our anchor institution approach. So we talked earlier about what Chelsea mentioned, what can we do in our organisations to both make sure we pay a decent wage, that we provide good quality jobs that protect people's health, but also that we provide opportunities for apprenticeships and for people with health problems to be included in our workforce. So there's a number of recommendations in the reports, which I direct you in. All right. On the actual report, I think they come on page 43, I think it is. Anyway, it'll be different numbers in probably most of your packs in the actual report. So page 46 has the full recommendations report, which I've been discussing with a range of partners and partnership boards. And one of the key things that I would like the board to consider is to undertake, as an anchor institution, an assessment around the work that they do on employment. And that's as part of the commitment that those that are part of the leadership board in Cornwall, so a whole range of public sector and other organisations have committed to do. So as I wanted to put in the recommendations on this paper, that's something the ICB commits to doing, and that's a self-assessment, looking at what are you doing in terms of good practice and maximising the work that the ICB does. And I think, to put this in context of the next paper that I know we're considering on health and work, the Work Well bid, which is supporting the 2,000 people that to stay in work who have health problems, is a really good sort of collaborative bit of work which joins together systems, but particularly work from the ICB, the council, and the workforces across the health and care system. So it's a sort of building a momentum that actually there is a role for organisations, NHS organisations, to play in the determinants of health and really supporting those building blocks. I think sometimes there's a debate as we should be doing secondary prevention and health services, but there's a key role, isn't there, in organisations thinking about how they can play a part to provide employment opportunities and keep people well and give them job opportunities. So I hope that's a helpful introduction, but it's a lot in the report, and I hope it was an interesting read for people. And I just ask that you review those recommendations.
Yeah, thanks, Rachel. Comments for Rachel, questions? Yeah, Calvin.
Rachel, I found the section on anchor organisations really helpful, and certainly recognise the 5 key areas of things that we talk about, not only in the ICB, but actually obviously our providers, RCHT and CFT. Given that RCHT and CFT colleagues have stepped out, I was going to offer to discuss that aspect of the report with them and actually recommend that we should consider doing the evaluation in those organisations as well.
Thank you. That would be really helpful.
Emma.
Thank you, Rachel. I think this is a really important report, and it sounds a little bit odd for me to now flip from my previous conversation about the financial impact on the sector, but genuinely we do feel that collectively as an ICB and as a county, we should be encouraging our steps towards becoming a real living wage county. And I know that's a long-term aim, but it is one of the things that will lift people out of poverty. And I think we've got some significant momentum across the county from some of our anchor institutions, but more work to do. So I know Patrick and I are having conversations about how our NHS colleagues can come on that journey with us, because we appreciate that there is a financial pressure, but this isn't something that we're seeking to do next year. It's something that I think we all need to be building into our future financial planning, because we employ a huge number of the population across our respective organisations, enough to make a significant impact on the health and well-being of the population. And I do think we have a responsibility as anchor institutions to go on that journey. It also strikes me, though, that there are a couple of immediate things. So the links between the musculoskeletal challenges and our elective care backlog, there are immediate things I think we could be doing that would solve or help to impact on both of those challenges, because where other places have done specific work around waiting well or supporting people with existing conditions, they have actually been able to reduce the elective backlog by virtue of people not necessarily choosing or needing surgical care. So I do think we need to be thinking in our, in the coming 12 months of how we can look at the potential impacts across both of those areas of work. And the final thing, and this is back to our own collective responsibility for our workforce, I don't think we do invest enough in staff wellbeing, and I think that's something as a board and as a system we really do need to do a better and collective job of, because it's no individual part of the system's responsibility. But actually, if we worked more closely together in terms of our sharing resources and investment, I actually think we could do a really good job of improving staff access to staff wellbeing support.
Thanks, Emma. Really good points. Susan and then Mary.
First of all, Rachel, thank you. It's a really good report, and actually it's quite helpful because an awful lot of the work that we're doing through the commissioning intentions, particularly MSK and planned care, is reflected within our commissioning intentions. And we know that we have a big issue within MSK, and we want to see less people being automatically put onto a waiting list where they continue to deteriorate, because we know some of our biggest waits are within trauma and orthopaedics. So really welcome that joint work around MSK particularly, because I think we could give a far better service than we do currently to our population. So, but thank you. The report was really, really helpful.
Yep, Mary?
Yes, just to flag up really things that are of a very acute experience for the social care sector is the numbers of people looking for work are largely single parents, and they cannot accommodate shift work, which doesn't help our sector at all. You can't get a single parent to work night shift, for example, and you can't ask the people who are flexible to cover all the unsocial hours. There is also the biggest cohort of people are working to tax credit thresholds. And we have people who will say, I'm not working at the weekend because you pay too much, or you've got to pay me flat rate. Or somebody told us the other day, well, I'm not working Christmas Day unless you give me the rest of the week off, otherwise I will lose X, Y, Z. And that's very, very real.
So some structural issues there to...
And of course, there's no childcare for out of hours.
Yeah. Tracy?
I'm just thinking about the NHS 10-year plan engagement and the ICB response that we need to do in December. We work within national pay scales, which are largely nationally funded when there's a change. and perhaps we ought to be promoting the importance of the living wage being built into those frames. I think there are some things that could be done nationally which would enable us to make a step change locally. So perhaps that's something we could include as part of our response.
Yeah, Steve.
So I mean, I totally welcome this report. It's certainly something that day to day in the surgery is alive and kicking. Welcome Susan's reports around, notes around MSK. That's so important as well. And again, borne out in the surgery day to day. Would also just like to highlight that access to mental health services is a huge part of that. And we've got areas in our county with fully transformed mental health where people have really quick access to good quality mental health. Other areas that aren't, and I do feel a little bit that in some of the commissioning intentions, the sort of mental health transformation journey hasn't quite been drawn out enough as it should do. So important just to carry on with that and make sure that all of our areas have mature, transformed mental health services and people have quick access to mental health. Equally, I would say that the Work Well scheme that we've started to implement really looks pragmatic and shows some real promise. So I'm very grateful to colleagues for helping support that implementation in Cornwall.
Chris.
So in some ways what I'm about to say reflects what Stuart's just said, but two points. As a GP, so first and foremost, I really thank you for the report, Rachel. I think it's excellent. But as a GP, I've spent many years talking about moving well, exercise, eating well, sleeping well, and being socially interactive, i.e. having good work, is far more important than probably any prescription I would write in terms of actually having an impact on that individual's health. So I really endorse it from that perspective. And of course, it segues beautifully into Lord Darcy and the whole 10-year plan around the fact that actually if we're going to be more about health creation, more about prevention, this is exactly what we should be looking at. So thank you.
Thanks, Rachel. I wonder whether, Susan, we can have a look at the recommendations, particularly around our own self-assessment of what we're doing on this. It does feel like it ties up with some of the channel shift work we're doing, particularly Steve's points on, mental health service provision, addressing MSK and things like this, to overcome some of the barriers. I think just on Mary's points, some of this feels structural, but I think Tracy makes a good point around whether we need to nationally advocate for things around living wage and better structures of pay that don't create these structural barriers to getting people into work. I mean, so there's money, there's the mental health and the MSK barriers, but also just our own duty of care or duty, I think, as an employer here to do a self-assessment. So, yeah, we'll come back on that. Thank you, Rachel. Patrick, yeah.
Yeah, I've not commented on the report because I'm going to be talking about some of the local work we're doing on work and health on the next agenda item. Yeah. But just on the point around the assessment, so our governance for work and health is through the ICB's Workforce Committee, and I think we could take that request and Rachel's recommendation into that committee to work out how we do the self-assessment across health and care, as well as core NHS employers. So I just wanted to make that offer. I think that would be the route that we could take that forward.
Helpful. Yeah. Thank you. Richard, and then we'll come back to you, Patrick, on the next agenda.
Sure.
Yeah.
Just, I agree with everything that's been said. An excellent report, Rachel. But just thinking what I might have expected to see a little bit more of is probably particularly in Cornwall, the ageing population means you reach a couple of points in here where 64 is a cut-off. And I think we'll increasingly see that drift past and people will be working much more into their 60s. What does that mean for healthy working as we're working increasingly at older ages? And I suppose the value of non-paid work. So there's obviously a real focus on finance. I absolutely understand that. But when you get into the mental health, particularly, some element of activity and work post-retirement is really key. And I suppose just seeing that and whether that will also help in a sense fit into some of the things that Emma raised about the issues about how we're supporting the voluntary sector through non-paid as well as paid. So I think there's elements in there which are not necessarily for this year's issues, but if you're planning forwards, I think that the agingness is a really key thing that I thought might just come out a little bit more.
Yeah.
Can I just respond on that? Because at the Health and Wellbeing Board a couple of weeks ago, we took a paper that described the public health approach to healthy ageing. And that's focusing on really, the sort of keeping people active longer, the opportunities to volunteer, making places age-friendly communities. So sort of more of a whole place approach. And that's going to culminate in a conference in January with Chris Whitty coming to talk about his Chief Medical Officer report around health in an ageing society. So there's an overlap there, but just thought a little plug for our event in January.
Thanks. We're going to move on. Patrick, you've got about 5 minutes just to cover the Workwell update. I know it's going to leadership board as well on Friday. Yeah.
So I'll be. We didn't want. We wanted to take the opportunity to follow up directly on Rachel's report on this whole area of work and health, to give an update of what we're actually doing in our patch in relation to this agenda. I'll take the report largely as read, but if there are a couple of things I wanted to pull out. So the key issue to make this really tangible is in Cornwall and the Isles of Scilly, there's 36,000 working age individuals who are not working due to health issues, and given that every employer, so this isn't health and care, this is every employer is struggling for workforce and is predicting their future supply of workforce is going to be an issue, whether that's retail, tourism, whatever industry, that number of people who are unable to work due to ill health is obviously an opportunity for all employers. The other thing to say is there's some unpublished NHSE data locally which says that in the next year 2,400 people will become economically inactive. It's an 8% increase in that figure. That kind of brings illustrates the scale of both the challenge and the opportunity in this area. It's a key local issue, but it's also a key national one, and the UK government are working on the development of, as Rachel mentioned, a great Get Britain Working white paper to develop proposals on this agenda, and they'll be taking that through to inform allocations of funding in the spring spending review. What we're doing in response to that, I'm not going to go through the report in detail on the Workwell programme, but this is the national pilot that we're one of 15 ICBs who are participating in that. We're delivering that programme in partnership with the Community Gateway. So we have commissioned a partnership of voluntary and community sector organisations to support the delivery, and they are the one-stop shop as point of contact for people who want to access the Workwell service. In the report, there is a link straight through to the little web page for that service, and what I'd like to do is circulate that to board members for just communicating to your networks about if you come across anybody who looks like they could access that would be great. We're aiming to get to 2,067 participants by March 26. That's what we're funded for under the pilot as it's currently drafted, as it's currently configured. Started on the 1st of October, and we're building the participation rates in that programme. The other bit I wanted to highlight was that this programme supports the Cornwall and Isles of Scilly economy as a whole. So this is part of our anchor institution work, and that's clearly linked there. The other bit to draw out as well is that we have established through that a work and health partnership, which is our cross-sector partnership for managing the development of this agenda. And one of the products we're required to deliver through the Workwell funding is a Cornwall and Isles of Scilly work and health strategy. And that work is going to be developed in parallel with the delivery of the programme. So a lot of the issues that we picked up in that discussion, thresholds on pay and what that does to prevent people accessing work, employer culture, learning to accommodate people who are able to work but have a limiting condition. All employers need to do more on that. And to the point around an ageing population and an ageing workforce, we're going to need to learn to get better at how we are more flexible at supporting people who are able to contribute, but where we might have to make adjustments beyond just statutory
ones.
Yeah.
So that governance infrastructure I wanted to highlight is where we're going to be taking this work forward. And the final comment I'll make is being a WorkWell pilot puts us in quite a good position nationally. So we're one of 5 ICBs in the country who are currently working with government on the development of their proposals for that spring spending review.
Yeah.
We're using our participation in that network not only to contribute our learning, but also to put our patch in the best position for any early release of funding that might arise. There's a lot going on at between Treasury, NHSE and DWP about who's funding what for what purposes, but we at least know that because we're in there. And there may be opportunities for us to be submitting our expression of interest into early funding that might come through that route in December and January. So my asks of board are, and I'll help you with this, but if you could publicise the WorkWell pilot, it's in existence and people can refer and they can self-refer into it straight away, that would be brilliant. And also be ready for updates on if our participation in the national networks goes well, we may be able to mobilise a bigger effort through our local partnerships and hopefully through funding.
Thanks, Patrick. Look forward to hearing the feedback from the leadership board as well on this. That's happening on Friday. Great, thank you. We're going to move on. Sorry, yeah.
Can I just say, so Patrick, it's a great initiative. I just think it's incumbent at this point, not again just on behalf of GP, but actually specifically in this case, colleagues will be aware of the crazy situation we're in, whereby we have unemployed GPs, because the issue, segueing back to finance, is that actually we have people who actually want to work for whatever reason, but employers can't afford to actually employ them in work, and that is all shades of madness. So anything that we can all do together to try and link these things up to the best of our ability at a local level, when I appreciate the wicked problems need some resolution at national level, would be really great.
Yeah, there was a concern flagged with Richard Meddings around the cliff drop of retiring GPs, and then we've got other GPs
and nurses
who could work and can't because they can't afford. So it is a more than a bizarre situation.
I just wanted to point out Neil's hands up if you hadn't spotted.
Neil, sorry, I didn't see you there.
Thanks, Ange. Very much welcome this report, and particularly the fact that you're involving place and spreading it widely. And also it's another example of how it's really important that the VCSE are involved in the design of all services. They have so much to add. There was one bit on page 6 that referred to some dissonance locally in terms of consent and signing people up to the project. Has that been sorted? And if not, is there anything the board can do to help that process?
The short answer is we have resolved that issue, so it's no longer a barrier to participation.
Great.
Good.
Thank you.
Thank you.
Thank you. I'm going to turn to next agenda item, which is we're just skipping ahead. We will come back to John and Kate's updates, but planned care and cancer strategy. Patrick, thanks for the update.
Thank you. Thanks, Chair. So the paper that you have in front of you, shame that Rachel's not here, because Rachel was very keen that we got this to board before Christmas. So an awful lot of work's been done around the planned care and cancer strategy. We have worked with our providers. What they would like is for the strategy to come to them and then they can enact it. We are going to showcase the strategy at the clinical summit, and it's just gone out. Is it the 16th of December, Chris?
16th, yeah.
16th. So part of the clinical summit will be handed over to how we get a delivery model into an implementation model into our planned care strategy. The paper, I think, is self-explanatory. I think it's a very helpful explanation of what we'd like to do. It's in line with commissioning intentions. It's in line with DARSI. It's in line with our joint forward plan. And when we think of planned care, we often just think of the acute trust in terms of waiting lists. Of course, we've got waiting lists all over the county, and we need to be mindful of that. And we also need to be mindful that children are often hidden in terms of waiting lists, so whether that's mental health
or just trying to access services around dental, for example, we have waiting lists. So we are taking a much broader view in terms of planned care. It's not just people sitting on acute trust waiting lists. So the paper takes you through in a sequential way the steps that when people are referred for treatment they have to go through, and I don't think we always make best use of those steps. So advice and guidance, when we look at advice and guidance, for example, we are still seeing a very high conversion rate from advice and guidance into first outpatient appointment. There are things, and we touched on some of this, Rachel's touched on it, particularly in MSK, rather than putting somebody on a very long waiting list, there are things that we could do, and we'll talk about that in a minute in the commissioning intentions about the integrated neighbourhood teams and some of the offers we can make through work within our integrated neighbourhood teams. So how we build a much more robust advice and guidance outpatient is going to be really important. We know that our waiting lists are often growing because our outpatient appointments are so long. So how we do outpatients is also really important. Whether we do that face-to-face or whether we do that virtually, again, is something I think we made very good use of in Cornwall even before COVID. But we need to make sure that we're not just popping people onto waiting lists when something else could be done. Having been a coup in an acute trust, the thing that really does dictate how efficient your waiting list management is your diagnostics. So if you have backlogs within diagnostics, both for people who are being investigated for cancer and not, that's a really important part of that pathway. So ensuring that flows and that we've got the right people with the right conditions on our waiting list is incredibly important. So again, the strategy is about being clear about where people are being referred to and when. We are seeing, and I will plug it at the moment, whilst we've got long waiting lists, we are, I think, still the best performer in England in terms of our 52-week waits. So that's huge thanks to all of the teams that are involved. So our population is getting a better deal than other places. And we need to continue because we are still nowhere near our constitutional standards, where once you're referred, you're seen within 18 weeks. We're not near that. We've worked very hard to clear 78 weeks and 65 weeks, hopefully clear by December. And then we've really got to make some inroads into that 52-week wait because we know that the longer people wait on lists, the worse their outcomes are. But equally, just simple operations, had they have been seen earlier, it's a difference between being an hour on an operating table to 6 hours. So the implications for people waiting are huge. So this strategy just really sets out what we're going to do, how we make best use of all of the investment that we've put into our community around community diagnostics, for example. We've got the elective surgical hub. We know that's early days, but getting some of those high volume, low complexity cases out of our acute trust into other areas so that we can make best use of our theatres within our acute trust is incredibly important. And we also have to use those theatres for emergencies as well. Yeah. So the join up, the message I suppose I want to leave with is the join up with the elective care strategy is very much integral to our commissioning intentions and that joint forward plan that we've all signed up to. Happy to take any questions because I'm sure I've answered quite a bit.
Thanks, Susan. No, I think helpful for the intro. We're going to just pause on questions. Terry's rightly flagged that with providers out, it'd be better to have the questions with them in the room because they will also have questions. I'm sure others have questions. I've got a question as well. So apologies. I'm just going to say we've received your update. We will come back to questions when they return, which they should have, but they haven't. So we're going to jump to what I hope is, Terry, tell me otherwise, a topic where we're less likely, it's less sort of necessary to have all the providers in, maybe transforming primary care strategy, which was at 12:25, if we can, with Chris.
I'm happy to.
Alternatively, we can take...
I might suggest we just take a short break.
Shall we take the break? Yeah. Okay, let's do that. And hopefully they'll be back in for that. And then we can pick up with questions for you, Susan.
Okay.
Yeah, all right. Thanks,
See
everyone.
how much everybody's remembered and you can all...
So 10 minutes?
Thank you.
Thanks.
Apologies, everybody, those on the screen and those in the room for that, but we've all got the boss. So, Thank you, Sanj, for taking us through it. Sanj joked with me that you've done the entire agenda, so I'd like to say thank you and goodbye. So, yeah. So more seriously, so you got, Sanj, to a discussion on planned care and cancer strategy. Is that fair?
Yes.
Where did you want to take us in that section?
So we've had the introduction from Susan on the paper, and we haven't started questions yet.
Okay, so questions.
I did challenge them to see whether or not they'd remember it after coffee. So what I said, Chair, was the paper's fairly self-explanatory. It follows a very logical route through how we manage waiting lists, and that our waiting lists don't just sit within our acute trust; they're across our county. And the work that we've done through the commissioning intentions, or working through the commissioning intentions, joins up with the strategy. But we also have been very clear that the strategy will also be part of the work that we're going to do through the clinical summit on the 16th of December. We'd like to present it there so that we get even more of an input from our clinicians, because it's very hard to socialise this in the early stages. What we'd like to do out of this is to pull together that delivery plan, but with our clinicians.
If everybody else is quiet, can I make a point, please? So thank you. We said it would come back in November. It's come back in November. Thank you, Rachel. Done?
Yes, thank you.
What I would like to pick up is, so we've just been on the webinar with Wes Streeting and Amanda Pritchard. AI and digital is coming across really strongly. So in terms of planned care, triaging, reading results, self-booking, all of those things, I think it would be great if we could have a section on AI and digital. So my husband went for an X-ray in Bodmin, so Margaret and Debbie. He said it was amazing. Saw his GP on the Wednesday, got a phone call offering different appointment times. Was seen on the Saturday at 5:30 in the evening. He was full of praise for a very responsive service. But he said, was it a radiographer that just pressed the button? Because they didn't do anything with my knee. They just put it in a position and then pressed the button. And I went, yeah, it will have been, because we haven't yet got to either automated X-rays or then describe what we're doing on the Isles of Scilly with potentially a piece of work around other people being able to take X-rays. If you think about the expansion of that into a whole range of other healthcare settings, I think we need to make sure that we are bringing this to alive in the strategy that we've got.
On it in part two. Is one of the things that I'd like to ask, and this is a general comment, but we'll hone in on this in a second, is that all our strategies need to start to think about how they land. And if they can't land in the current year, when we go through the rest of the day, and we're going to have a conversation soon, next, on commissioning intentions, are these strategies actually starting to be really woven into our commissioning intentions of a nature that is more than a pilot? We've got some serious commitment that we will have scalability of these things at pace.
Absolutely, but also it's not just the commissioning intention. That what's in the strategy is building on what we've already done. So we've got diagnostic centres, community diagnostic centres. We've got the elective surgical hub, very early days, but we are pushing the envelope on how we do planned care across our county. So the commissioning intentions are there to take it even further. Chair, but absolutely is interwoven, and it's also a reflection of our commitment not only to the constitutional standards but to the joint forward plan and the overall health and well-being of our population. We know that harm gets done to people when you stay on waiting lists too long. So some of the work that we'll talk about around the integrated neighbourhood teams is, how much advice and guidance can be done at place that stops people then converting into a first outpatient appointment, which then commits them potentially to a long wait.
So we're talking, aren't we, about having a robot in Cornwall? Mm-hmm. I do wonder, because robots have now morphed into AI-led robotic surgery, where human error isn't part of it because the surgeon's not performing the operation. I do wonder whether we need to use this strategy to jump over one or two of the things we might have planned in the olden days, to look at what we should be planning in a digital and AI world. And Kelvin, a bit of provocation around that I think would be really helpful.
Okay. Should we move on to the recommendations? So part of the reason why I asked Susan the question is that the recommendations I think might be subtly split out, because I think members of the board who were asked to agree the direction of travel and set out in the strategy, I think we're all signing up for that, yes? Yeah, I'm getting lots of nodding there. It says subject to ongoing clinical engagement. Can you just clarify what does that look like and by when?
So that's continuing. We've already spoken to our providers who wanted us to complete the strategy and then go through it with them in terms of that delivery. We are launching it, if you like, at the clinical summit, where we had a really successful clinical summit, and we'll continue then, Chair, to work through the CRGs, the clinical reference groups. But as I've said, this is not just about our acute trust. This is about waiting lists across the whole of our system and how we get into those.
Okay, so that's subject to that. We're happy with that. And then it says...
Can I add another point? Is that
on
okay?
the clinical bit.
Can
I?
Oh yeah, you go. You
Can I just finish this because there's the recommendations bit, and then it talks about detailed work underway on the commissioning intentions in the recommendation. So does that mean that we will have some substance in the December board meeting based on this particular stream that will be clear on scale and pace and resources? And you're nodding, so I'll take that as a verbal yes.
Yeah.
Lovely. Thank you very much. You wanted to add?
So again, it's just come from the discussion that we've had around different points of delivery. So part of that commissioning intention needs to be looking at which other parts of our system, and Susan, you mentioned it, but we need to be explicit, would we move surgical procedures to that can be done in a clean room, so that you don't need to be, let alone not needing to be in a special room, not in a very technologically enabled hospital. So I think we need to engage with general practice, start looking at how we can move some of our services around to give space in this place that can do the complex stuff, but also to mean that general practice are able to do more.
We covered that off while you were out. So no, it's fine. We did talk about that high volume, low complexity, and how we get some of that out of the acute trust to allow the acute trust to do the more complex stuff.
Thank you. Margaret?
Just by way of example, we have some low-tech surgical space in some of our community hospitals that's underutilized. Well, it's not used anymore, hasn't been used. So we could allow GPs to use that.
Thank you. So I think... Rachel, sorry.
Again, not part of the conversation. I think, firstly, it'd be good to hear a bit more about community weight going back, and I think that in terms of the resources and the assets. So when it comes back and having had that discussion, and also potentially the community weight, and the second one would be in terms of the work that Devon are doing around repatriation, particularly UHP in a relationship with UHP, and how that plays out as well. That
we'll bring that back in December. Is that what we're saying?
What were you going to say before I jump in?
The second bit that Rachel's mentioned, we need to say it's quite complex work, because it will be around bringing activity out of London into Plymouth and from Plymouth to us. Yeah. So I think we should start the work effectively around specialised commissioning. There's a strategy going to be written for specialised commissioning on its own that this needs to dovetail with. So I don't think that would be for December. I think that would be nearer for April, May time.
And the first element then? Can that come back in December?
Potentially, yeah. Community weights. Yeah, I mean, my sense is this, and also engage with our NHSE colleagues who are subject matter expertise. But this is a sort of iterative process, I think, that will evolve over the next few months.
And it mentions within the paper that relationship that we need to have with our networks, whether it's ODNs or so. That's all part, and the work that you talked about in the second point. We've got, and I never remember the name. It's PASP, isn't it, Chris? Peninsula
Sustainability Programme.
Yeah, so those conversations are also going through that forum.
Okay, so Susan, are you content we have the recommendations nailed as you want? Lovely, thank you very much. Thank you, Terry. So let's move on. So we're going to go back now in the agenda. We'll do my update and then we'll do Kate's and then we'll be back on track. So I just want to pick out a couple of points from mine. One is to just state what I think is the obvious. It might be politically lost in some of the messaging again, and we've already had one instance this morning on some of that. £22 billion sounds like an awful lot of money if you think it's extra. But in fact, we have a real reality across the NHS where it's already committed to and done. So in fact, when I wrote this shares report, I suspected that we also ought to probably be based on a flat cash, particularly for next year. I think we need to prepare beyond flat cash now and actually for productivity efficiencies, because I think that £22 billion has quickly been swallowed up in a variety of places. And it's actually over a 2-year window, that comparison, by the way. It's not sort of a 1-year comparison. So I just want us to be really clear. If you think there's £22 billion and we can shoot for it, it's probably going to be the inverse. A lot of it is already committed. So I just wanted to make that point out and in public. The second one, Rachel, I know Ali's not here, but on behalf of Ali, who's our statutory partner for both, and yourself, who sit on the Cornwall Council, in terms of the integrated care partnership development work, to have got really to the stage that we're at, working through Health and Wellbeing Board, the combined one. I know it's going to be separated out, but through the ICP as well, I think it's real testament to the collaborative working across both councils and the ICB and our partners to actually have got to the point where I'm hoping in the recommendation here, you can see from the attached, that we need to be able to not just get you to sort of note my chair's report, but use the chair's report as the vehicle to actually get the board to basically support the proposal on the next stage of the integrated care partnership. So the annex isn't in my thing here, but proposals that are in the pack. I'm not sure it's good.
I think it's there.
No, it's not in the back. No,
not on the board pack.
No.
So, okay, no, I saw them. It's not been uploaded.
We'll get it circulated.
Right.
Afterwards, and then we'll have to
What do we do?
I think there was an intention that we took the same paper back through the cabinet and our board, so perhaps we could cover it off at that point.
I think we're going to do if it's all right with everybody, because yeah.
This is the ICP. Yeah. Could we get some clarity on it? Because I've heard several different versions looking at the same paper. So, are we proposing a change in membership? Are we propose? So, if you look at the list of membership, then who's being? What can we just have some clarity on what topics are being covered by whom and who the attendees are going to be?
Yes,
what I heard at ICP was that we were just going to have health and well-being and ICP kind of having their separate meetings at the same time, if that makes sense.
I apologise that the paper which was meant to be attached to mine, and I've obviously read it, but assumed it was actually uploaded to admin control. I hadn't spotted the gap there.
No,
has that level of detail on it, and through the collaborative discussions through the ICB colleagues and with both councils, that's been discussed through a variety of places. And like I say, it's been through the Health and Wellbeing Board, which we sit on. Been discussed at the council, is my understanding. Is that right? Yep. So it's been through the council. We've spent a lot of time making sure that if you build on the fabric of what we've got now, which is effectively a membership group in the ICP that is made up of a 50-50 relationship between the NHS 50% and then the others being made up of the other 50%, that is going to be continued as a theme into the ICP going forward, but it's going to be a different mix of people. So there will be increasingly representatives from the providers on that board. There will actually be a slightly different mix of the way in which the Health and Wellbeing Board for the Council of Isles of Scilly will work, because they want to go back to their former role of having two separate Health and Wellbeing Boards. I apologise, this is all laid out. So we've got, I looked to the company secretary, got two ways of doing this. I can either circulate it and basically say, subject to everyone being content with it, we'll press on, or if not, we'll have to bring it back to the December board meeting. I don't think that's a problem from a council perspective, because this isn't going to go live until the new year anyway. Yeah. So actually, why don't we do that? Why don't we actually...
We lay it out really clearly on what's changing and who's participating and where are they participating and what the remit for each of those groups is.
Yeah. What we'll have to work through, and this is still going to be in the development phase, is they're going to be meeting back to back, right, with a similar membership, and we have to work out what actually goes on to the Health and Wellbeing Board's agenda and actually what goes on to the ICP's agenda. So we have had a number of workshops to work this kind of thing through, and it's obvious at one level until you get into the details. And well, where does this one go and who does that? Well, my position on this, just if it's helpful, if you have the same group of people on both of them, they're going to be talking about it. There's just an element of two statutory implements are in place that set up Health and Wellbeing Boards, has to go through a process. And then there's the Health and Care Act that set the ICPs up, has to go through a process. So we're trying to manage membership of two statute machines, trying to get coalescence of membership that makes it clear what's on agendas. And if we see it above all that statute problem that says, how do you have a group of members that have to work through the longer-term strategy for health and care. That's what they're trying to do. Part of the linkages of this, I think it's fair to say, is May, of course, there's going to be local elections, Rachel, yeah. And therefore, I think it's part of the reason why this has got a bit of a time to run is, of course, there'll be implications for the view of a new council that might be coming in as well. So
I thought we can take our time then.
we can take our time, but it is going through the stage processes of recommendations. I don't know if the Council of Wales or Scilly have nailed theirs yet, but Cornwall Council have. This was meant to be today, our version of that, for it to go to the next stage. I don't think anybody will be unhappy with this. It's had a lot of ICB board, executive and non-exec engagement in it, and lots of workshopping with some facilitation to have got to that point, and lots of collective negotiating to actually get to a point that everybody is happy. So I only can apologise again that it hasn't happened. So we're not going to decide anything on that one, colleagues. I'm glad I raised it.
Can I just mention the Isles of Scilly?
Yep.
So there is I think for me, an outstanding action to be working with Juliet Ferris around how we have the ICP version for the Isles of Scilly. So or the health and wellbeing ICP version. So we'll bring that back once we've got the paper agreed with how we're going to operate it next year.
Just to save waiting for another 3 weeks for stuff, though, could you actually get the paper that was meant to go out informally circulated to the board so we can actually start? So Margaret, probably from as soon as that gets out, let's take a look at it, give us a shout, and we'll chat it through. And anybody else too, we'll chat it through. I'm really confident that you'll be pleased with it.
We talked about it at the ICP, and what's kind of thrown me off is some feedback I've gotten, some papers I've gotten elsewhere that sort of don't seem to align with what I thought we had agreed.
Okay.
So it'll be interesting to make sure that we could just have
And then we can talk
clarity.
about where you got those from too and on as well. Rachel.
Can I just say they're published already, the slides, and are available both under the ICP papers that are published and they're
I am
online.
a member of the ICP.
Yeah, they're
so
online. Yeah.
I have seen the paper.
Okay.
I think my point is that I think there's some difference of opinion on what is actually being said, and I'm seeking clarity. Okay, that's all. And I think that's what you've just set out, John. So I'm happy with that.
Very good. Very good. Thank you for reminding me. This was agreed at the ICP.
Yes.
I was off ill that day, wasn't I? So yes, I
That's how I started my conversation.
Yeah, that's right. Yeah. It's only because I didn't attend it. I'd forgotten it. Okay. I'm so glad I raised the chair's report. Okay. So let's swiftly segue into the chief executive's report.
Please be kinder to me. So there's quite a lot in my chief exec's report this week, and I'll take most of it as read. The 10-year plan engagement, Lucy Tucson, and with all of our comms and engagement teams looking at how we get a strong engagement across the county. We spoke to 10,000 people last year, so we've already got quite a lot of feedback to go into the 10-year plan engagement, but we will be making sure that the consultation in a box is available at a site near you across our county over the coming weeks and months.
Yep. Since your chief exec update was published, the first is there's now a requirement for an ICB response as part of phase 1 by the 2nd of December. We will, as you've said, base that on all the work we're doing around commissioning intentions, our integrated strategy, and as you've said, the engagement we've already done. We'll provide a survey for all the board members here, because that will be ahead of the next board meeting, so everyone's got an opportunity to contribute. But it does give us an opportunity to do that horizon scanning as to what we would like to see and what hinders and supports our commissioning intentions being developed at scale. So we will ensure everyone has an opportunity to contribute here. That is over and above and ahead of the engagement we'll be doing with all providers and other members, because the engagement actually doesn't conclude until mid-February. So this is sort of an early indication. And the second thing, which has come out this morning, is that we've had a request from NHSE for 10 system leaders from each ICB to attend an NHSE event. There are some specific requirements around there needing to be, for example, a digital rep as part of that and a clinical rep and so on. But that's on the 5th of December, but we need to respond by Monday. So I'll link with yourself and John, and we'll get something out to agree which members of this board are involved in that.
So NHS chief execs will already be at that meeting with chairs, I think. So we're just needing to make sure that we get people who won't have got a formal invite. So the next bit I just want to bring us into is looking at the CQC and the actions to strengthen patient safety, and then to link that into the integrated care systems. So on page 5, that the CQC has concluded that nationally financed and joint forward planning workforce depletion are some of our challenges. So the call we're hearing, really, the signal that we're hearing very clearly is that it's our job to make sure that our services are safe, and that we can do so within the financial quantum that's given to us. So I think we've got quite a lot of work to do, particularly over the next few months, to make sure that over the winter period that we are making sure that our services are as safe as possible and that vulnerable people are getting access to care in a timely fashion. And then linked to that is when we're looking at our performance, which is on pages 8 and 9, around the emergency pathway. We've heard this morning that no criteria to reside is going to be removed, and it will be replaced with estimated day of discharge. But it will be specialty specific, which I really welcome, because the actions in some parts of, if I'm on an orthopaedic ward wanting to get home, it might be a different set of actions than if I've got dementia with long-term conditions. So we will be starting to look at what that means in terms of our UEC performance, but I think it will allow us to be much more specific about actions to address specific circumstances. I'd like to raise one hot topic that's not in here, which is around getting ready for a difficult next year. So all of the messages that we're hearing is that money was tight this year, money's going to be even tighter next year. And that's not just for the NHS or for our local authority colleagues. It's also, as Emma raised very cogently this morning, it's for the range of services that we rely upon in order to be able to provide the best possible care for all of our people. And general practice actually is the only universal service that's available now. So we need to make sure that general practice is consistently available and that people are able to thrive in providing care. So it is a challenge, and we could become very dispirited about it. But one of the things I just wanted to reflect upon as we go through the rest of the agenda, we have delivered 2 years of financial balance, and we've done what we said we were going to do. This year we will deliver our third, it's what we're planning to do, and that isn't without difficulty. So we are a team that has found ways of working together for our people that gets maximum value with our eyes continuously on safety. So as we go through the planning round, and this was supposed to come before we talked about commissioning intentions, our eyes need to be upon safe care for the most people and just being really clear that we are the guardians of the money, the quality and the outcomes. So that should guide our commissioning intentions. And that's it for me, John. Other than the parliamentary award. So isn't it nice that Cornwall and the Isles of Scilly gets recognised for innovation that is focused on vulnerability, doing the right thing and working in different ways. So it was a pleasure to be with Emma and Errol Caudle at the Queen Elizabeth II Conference Centre in London. I didn't think we'd win, and boy, we did, and how fab was that. The other thing that was really interesting, though, is if you looked at the awards that lots of other people were getting, it's work we're already doing. So over the course of the next year, I've spoken to Tracy about getting Lucy to be bringing things forward so that we are highlighting and celebrating the work of our staff, and we should be submitting more applications into awards so that we can really profile our work. So thank you.
Yeah, we should endorse. Congratulations to the team and the partners that actually were part of that.
That's fab.
Well done. Any questions? Yes, Steve.
Not a question, but a comment, because I wasn't in the room during the committee partner report. So I just wanted to make a comment briefly on elective care. So Kate refers to planned care performance in the report, which is really helpful. I can also update board members that this week Royal Cornwall Hospitals NHS Trust received formal confirmation from the National Director of Elective Recovery that as a result of the really significant work to reduce waiting times in our planned care services, that we have been de-escalated out of tiering. I think board members will kind of recall there are 2 levels of national escalation, Tier 1 and Tier 2. Tier 1 being the highest level of escalation. We were in Tier 2 for elective performance, and Sir Jim Mackey wrote to us this week to confirm, following a huge effort within RCHT and across the system, that in recognition of that we've moved out of elective tiering. So that seemed to be a significant step And I just wanted to acknowledge that and recognise a huge amount of work across the trust and across the system to achieve that.
And as part of celebrating stuff, we need to mark it, don't we? Because that is no mean feat.
Yeah.
We go back to all the other things we had to control in year. That's amazing. So I think we should formally note it.
Well done to the team. Yes, please let's note that. Okay, anything else before we finish?
Tracy's just brought my eye to something on my report that I didn't say and I should have done around integrated care systems. We are going to have to develop an assurance framework that shows that we are dealing with inequalities in health. So instead of talking about it, we need to have the dashboards. Now, Ard and Gem have helped us develop develop place-based inequalities dashboards. It would be great, I think, if we could have an informal opportunity for board members through a lunch and learn maybe to see how the dashboard works. It's amazing. So we will be bringing that forward, but Tracy will be working with us to make sure that we can show that we are assured as a board that we're making a difference. And then the last thing, Rachel's just reminded me, Richard Meddings came to see us, didn't he, on Tuesday. So Richard is the chair of NHS England. We took the opportunity to profile as much of the stuff that we've done that's innovative and is making a difference. So Margaret kindly hosted us on CFT's land, and we went to see the partnership that is the Community Diagnostic Centre, talked him through how we use it not just for planned care, but in order to support our community assessment and treatment units and the same-day emergency care for frailty. So he was really impressed with that. Ali Bullman came to meet with him, and what was really, I think, reassuring for me was that when he asked Ali, do you think the NHS has got more money than it should have got, and do you think it's got a very good settlement? Her response was no. Now, that doesn't chime with what some of our local authority leaders are saying. So within our county, we do jointly understand that we've all got difficult roles working together with what we've got. And then we went to the sanctuary at St. and Richard had the opportunity to meet our voluntary sector organisations, general practice, and to talk about the many and different ways in which we are making a difference across Cornwall and the Isles of Scilly. The facility itself is amazing, but the enthusiasm, the vibrancy and the intent from everybody in the room to make integrated neighbourhood teams work was fantastic. So he went away thinking we were great, and he told us we just need to grab the opportunity and make sure we do it next year. So we are going to follow his wise words and make sure that we do that.
Thank you. And it was a great day. And the only thing we're not going to follow in terms of advice is we are going to have jam first on our slots. Okay.
Debbie's hands up.
Yes, I can see that. Debbie.
Yeah, thanks for that. And I'm really sorry I missed it. Kate, I just wanted to go back to the inequalities dashboard just quickly. Can I just clarify that this is not just going to be an ICB tool, but it will be available as a resource for all providers, including primary care, and a tool that we could use to underpin our move towards integrated neighbourhood services? Did I understand that correctly?
You did. So I think the tool belongs to the integrated neighbourhood teams, and that we should be supporting them in how they use it. And that will mean that they'll make greater asks on us as holders of statutory services for how they could meet local inequalities. So I think it could be a great development for all of us.
Happy with that, Debbie? Rachel.
Very happy with that clarification. Thank you.
Thanks. Rachel?
Yeah, and I know that public health colleagues will support in sort of the utilisation of some of those tools. Can I just in terms of celebrating some of the things that are less well seen in health inequalities, there are a number of NHS accelerator programmes that we've got been doing underway for Cornwall under the Innovation for Healthcare Inequalities programme and the IHI Institute for Health Improvement, which I'm not sure have been visible to the board. We're actually taking an update with colleagues from Public Health and the ICB to the region, and I'm aware that perhaps that hasn't been visible locally. So I don't know if that's something we want to consider in terms of a board update in the coming year.
I think it might be quite nice to have a regular update around inequalities. Yep. So is Andrew Abbott working with you around that specifically?
Julia.
So one of the things, Rachel, which you've prompted me to think about is that as part of yesterday's interesting set of announcements, one of the bits of paper that came with that is for both providers and ICB boards across the country to actually just reflect on its agendas, focus, etc. And Terry and I and Kate will be picking that up, and things like that we need to think through quite how we weave into any future way in which we do business. So there's a bit of a reflection moment going on nationally, but we'll do it locally as well. Yep.
You touched on urgent emergency care, Kate. I know last time we had a big session on it, both the winter plan and current performance. Don't have the IQPR, I don't think, this month, so I just wondered, can you update on where we're at? Did the things we talked about last month start to come into effect? Have we seen any improvements?
So, so we've had, in county, we've had a really difficult month since our last board. So we've seen longer ambulance holds outside the hospital. We've seen a consistent number of people waiting for beds on any given day. And the ambulance services cap mean time has moved around a lot, but in the wrong direction. So very swiftly, probably about 2 weeks ago, we asked Kernow CIC if they would support us in setting a single point of action up sooner than it was planned to do so. So CFT had planned for a single point of contact to go live on the 15th of November. So putting a GP 8 till 8 in Kernow CIC has reduced the numbers of ambulances flowing into RCHT, but it's still not giving us enough stretch across delivery for RCHT to de-escalate. Ashlyn Crombie, who works for Susan, has been doing a lot of work on the current no criteria to reside people, so we understand it better. But we later on today, Steve and Debbie will be talking about some actions that I asked our providers to lead on as we go into winter, which is making sure we use the virtual wards, making sure discharge to assess is flowing, and admission avoidance is happening at the front door. But as we stand today, we are in a very challenged position.
So as a general point, you know, it's really great that we're talking strategically and looking forward, and we're a strategic commissioner, but will we get back to having the performance in the meeting so we can review the IQPR?
Speaking to Terry about agendas and with Kate and what's coming up, just for the short window of time while we're getting into commissioning intentions, we're going to roll every second month IPR. So we'll be coming back next month. We'll be back to normal once we get, but agenda's going to get crowded out and we won't spend enough time on the big strategic stuff for next year if we're not careful in the next window. Thank you for raising that. Steve?
I'm certainly mindful of time, John. I appreciate that, but if I could just add a little bit of context to Kate's summary to perhaps give some more information. So a number of significant steps have been taken to address the challenges that you described, Martin. Our third frailty same-day emergency care unit is now opened. As board members are aware, we had one unit opened in Bodmin, one in West Cornwall Hospital. We now have a third unit operating in Cambourne and Redruth Community Hospital, so all three are now operating. The next step is to move to a single operating model across all three. That's scheduled to take place at the start of December. Kate's already mentioned the single point of access, which was accelerated and opened. The first stage of a virtual ward cardiology pathway is commenced. So there are a number of rapid steps that are underway to directly address the challenges that you've described. And Debbie and I are intending, as Kate said, to provide some more information about the progress of those actions in this afternoon's part of the meeting as well.
And every week, every month, you know, we have a list of actions that are about to start. So it'd be great to the next month see the actual progress and some benefit. Oh, no, that's the bit we never quite get to yet.
Yeah, Susan?
Yeah, if helpful, I asked the UEC team, Urgent and Emergency Care team, I've got to stop using acronyms, to pull together a slide deck of all of those initiatives that we put in last winter, and including the SPOA, and what that's yielded, so we can put that along the IPR next time, Martin, if that's helpful. And I think that gives us a good basis for provider updates on UEC.
Thank you, Terry.
Yeah, and just to add, I think we've agreed that will go back through the Finance and Performance Committee, which is the committee that needs to own the oversight of that at the next meeting.
Very good.
To the board.
Thank you very much.
Can we just reference that Ian Sturgis, who is an expert in UEC redesign and drives performance, will be joining us on the 25th of November, and he'll be with us for 6 to 8 months to work alongside Steve and his colleagues, but also to work alongside Debbie and her colleagues and us, so that if there are gaps in any part of our system, he will call it out very clearly, and then be working with us to work at what we do about it.
Thanks, Kate. So what it's just reminded me of, and Sanj prompted me before we broke, what came out of your committee is that in readiness for the board-to-board with RCHT, we need to agree pretty quickly what we want as the agenda based on that, because it's going to focus on both the money and UEC. So we need to agree that and get that out sooner rather than later, please.
Okay.
If you can make a note of that, would be great. Yeah. Lovely. Shall we move on from Kate's report? Yeah. Thank you very much. Gosh, let's move on. So, commissioning intentions. Susan, we're in your hands.
Thank you very much. Thank you, Chair. So the paper that you have within your pack around the strategic commission intentions, thank you to Tracy and her team for pulling this together and continuing to iterate it as we go through the work that we're doing on each of the 6 areas within the commissioning intentions. The paper that's been brought today is the final iteration to come to board on our commissioning intentions. And the other thing that I would just like to talk about, because I've been hearing a general theme this morning around more information, more data behind the commissioning intentions. We are working on that. It's a very rapid piece of work. And at the same time as developing our project initiation documents, we're also talking to our providers so they don't feel they're being blindsided by any of the intentions. Everything that we are doing through the commissioning intentions follows on from Darzi. It also is taken from our joint forward plan, so there are no surprises within commissioning intentions, and it's very much for those of us that were at the True North event those years ago, it's really bringing that to life in terms of how we shift services. And that service shift is incredibly important, not only for our population to get the right care in the right place, but also for all of our providers to be able to be efficient and provide the care that's best suited to that skill set. So it's really important that we're able to get behind the commissioning intentions, bearing in mind there is still more work to do. The piece of work that we've done alongside the project initiation documents, and we have all of those, Chair, it's just we didn't bring them to this meeting because it is a tome, as you would expect for documents. We have looked at percentages in terms of shift, what that would mean in terms of activity, the piece of work that we need to do with our provider colleagues, with our finance colleagues, and further commissioning is making those actual numbers and giving them value so that we can see the scale and challenge that we've got. The commissioning intentions are multi-year, so we're setting out very clearly what we will do across 25-26 around end of life, which was one of our priorities this year, around frailty and our long-term conditions, those being diabetes, cardiovascular and respiratory. The other piece of work that we've also done at Pace is pick up the integrated neighbourhood teams, and we had quite a long debate at our last board about what we call them. We're all agreed they're integrated neighbourhood teams. Our primary care hubs are something slightly different. But what we're seeing through the work that we're doing with commissioning intentions is the real benefit and opportunities that these integrated neighbourhood teams will bring. We have 16 across our county, and what we're proposing through the commissioning intentions is that we work with 4 in the first year. So that's Penwith, North Kerrier, St Austell and Bodmin. And we've looked at what we can put through those integrated neighbourhood teams. We've already got examples, and Stuart reminded me of the paper that Tom Fontaine wrote around paediatrics, and the scale of work that can be done in the integrated neighbourhood teams that we can't quite replicate in other parts of our system because it's just not the right place for the type of work that goes through. So we'd like to build on the integrated neighbourhood teams. We'd like to be able to show you the services that we can put through there, what the benefits will be, that not only the return on investment in a financial sense, but also to our population, and how we then link that, as we've already talked about, to things like the planned care strategy. So getting people seen quicker is so important for their long-term health, particularly for children. We know that children often spend the longest on waiting lists. So being very clear in our commissioning intentions that we're focused on that core 20+5 is incredibly important as well. So the paper sets out where we're at, Chair. Sorry. It gives the final intentions. The work that will be done between now and our December board is really bringing together the numbers and doing more of the engagement. And again, we will be talking about commissioning intentions through the clinical summit. I can see lots of hands popping up, so I'm going to stop right there.
I could just ask people to be a little bit more obvious when they put their hand up, because doing that doesn't actually help me too much with these glasses on.
They're either putting their hands
Kate's
or
going to go
fidgeting.
next.
On our regional call this morning, our new Director of Public Health for the region, Justin Barney Bennett, he I made a comment that the evidence around these movements from secondary to primary care are well evident, they're really old, and they are boringly consistent in terms of the percentage returns you get for the movement of work. So instead of us querying the evidence all the time, we just need to use it. Because I believe when we had fund holding practices, that's exactly what they did. They brought secondary care in to reduce flows into a hospital, and to mean that they could develop their practice infrastructure. So it's there, it's old, it's valid, but we're going to get Mark Britnell to come and talk to us in January. For those who don't know Mark, he was the global head of KPMG's health practice, and he's now the chair of the Greater Manchester Health Innovation Health Improvement Network, and he also is advising on some of the national policy. So he sent me a slide deck which I'll share, but he's also very clear: integrated neighbourhood teams and integrated systems produce better outcomes with lower spend than the current distribution of services that we've got. So I just think we need to back the evidence and make sure we use it.
Anybody else have a hand up? Steve.
Really welcome the paper. There's been good engagement from a provider sector that Susan has outlined. So I think it puts us in a really positive position. And I think potentially some of this could help inform colleagues elsewhere across the region in terms of the opportunities that we're facing. So very much supportive of it. Two observations or questions. One is, as Susan's outlined, it's critically important that we have clinical engagement in shaping this strategy and its implementation. There is also a tension in how we release sufficient time for that to happen without impacting on the provision of services. So just recognising there is a tension there that we need to manage and work through. The other aspect is whether it would be helpful to see alongside this the local authority intentions, and this rightly focuses on the things that we can directly change and directly influence, which I strongly support. But whether there's a mechanism we can see alongside this, perhaps in December, the anticipations that local authority have from a social care perspective. And I'm mindful here of the really significant financial pressures that local authority colleagues face.
So I'm just going to make an observation. I'm going to bring in Susan. I don't know whether Rachel, whether you want to comment or not, and then Tracy. So in the paper, it talks about the clinical engagement summit on the 16th of December. My concern is we've talked, I thought we'd agree that at the next board meeting, which is on the 12th of December, yes, the paper will be here with papers out on the 5th. It could be difficult to actually have, like, this is what we're going to be doing without clinical sign up to it. So aren't they the wrong way around?
No, so I've mentioned the clinical summit because it's an incredibly important summit, not only for this, but also for our elective care strategy. We are engaging with the Trust. I've spoken to Chris. We recognise, Steve and Debbie, that getting to our clinicians is really important, but also very difficult as well, because we're doing this at pace. So our clinical reference groups are key. So where we've agreed the commissioning intentions are the priority for 24-25. That's been our focus for the clinical reference groups to be set up. We've also I managed to get very quickly.
They're meeting regularly, I take it.
Sorry?
They're meeting regularly, I take it.
Yes, they're meeting regularly, but also the programme of care leads are going into the Trust to talk to teams. But I've also suggested to Smitesh and Stuart that there may be an opportunity for them to meet with some of our clinical directors in the coming weeks to talk about the integrated neighbourhood teams and the benefits and how potentially we could release them, because then it's clinician to clinician, which I think is far more powerful rather than waiting.
Colleagues, can I just rehearse what I think I've heard? Mm-hmm. The clinical reference groups and the clinical teams are engaging on a regular basis. We'll go into our board in December, and then the summit is more of a collection of,
yes,
we've had all the clinical engagement, here's the board's view, and it's a sharing moment. That's what I'm hearing. Is that right?
Yeah.
Lovely, thank you.
The only other point I was going to make is Rachel gave us a really good presentation. I don't want to steal any of Rachel's thunder, but some of the work that we need to do around areas like MSK is going to be incredibly important. So absolutely, Steve, it's a great point, and I think that join up with our colleagues is going to be very important.
Rachel, would you like to make any observations?
Yeah, thank you. And there are commissioning intentions for the council that are published on the website. So I think, this, it was raised last time about this isn't a joint commissioning document, it is an ICB document. But of course, that joint working, I'm not sure where that's happening. So I think probably a question for those. I've asked to be engaged around the ill health prevention commissioning intentions, and I haven't seen that input sort of being included, or there's not a mechanism for us to discuss that. So I don't know where that's been missed, and perhaps we can pick that up with outside of the room. But they don't seem to cover the sort of breadth of ambition that I think I mentioned last time. So, but adult social care commissioning intentions are published, and the main document being delivering better care. Steve, just to sort of point you to that.
You said you wanted to say something in response to that.
It is really. So at our last Integrated Care Partnership Board meeting, we talked about the importance of, just as Steve said, looking at those things side by side. We agreed an exec-to-exec meeting between the ICB and council colleagues, where we would set out our commissioning intentions, both from a health perspective, adult and children, and public health perspective, and then bring back to the next ICP meeting those things that we can do independently, and those things we need to come together, which will form our joint commissioning agenda, which will then feature as part of the ICP Partnership Board agenda for the coming years. There's no reason that can't come back here as well, but I think that's where we'll discuss. Yeah, we've got a meeting ahead of the ICB Partnership Board meeting on the 19th of December.
Come back here in January, February, or
yeah, we can bring the output
no
of
rush,
that here.
point.
Yeah, it probably needs to feature as part of our integrated business plan going forward, so we can see how that work comes together.
Yeah, timeline, so that we triangulate it all. Rachel, you want to come back?
I really welcome the opportunity as Director of Public Health to just have that conversation rather than waiting to an executive and doing that formally, because I feel like that's the way we should be working.
Okay.
So I agree, Rachel, and we have talked, haven't we, about joining our executive on a monthly basis. Diaries are difficult, I know, but I think this is Chris who holds this portfolio from an ICB executive perspective. I think we need to see more, Rachel, visibility around the work that public health is doing as part of the NHS core offer, and how that binds us together as part of this board, but then also how that then segues into the ICP. I think that would be really helpful.
Very good.
I'm happy to have that conversation, but I'm not sure where the mechanism to do that is outside of a formal exec-to-exec, which is not where I think it would be useful
with Terry
to
to note that, take that offline, and maybe you and Kate resolve that, or you and Tracy resolve that?
I think Chris and...
I'll pick it.
Well, let's be clear.
I'm happy to pick that
Rachel,
up.
are you happy with that?
Put that with...
Are you happy for us to note that this with Chris?
Thank you.
Lovely. If you could make a note of that, and let us know how that goes, please, Rachel. Thank you. Okay, let's move on, if I may, then to the recommendations. So, the recommendations are to approve the strategic commissioning's intentions set out in Appendix 1. Everybody happy to support that? All right.
Neil. Neil's gone down.
Oh,
Neil.
That's your hand, that's all. Go for it, Neil.
Yeah, it was just to say that, picking up on some of what Rachel was alluding to, I'm sure if Nick was here as chair of the System Quality Committee, if we take as an example the diabetes work that went on, it's really vital now that as we develop integrated neighbourhood teams, whilst we're anxious to see the level of clinical involvement from partners, that they are aware of the push in system quality development for the prevention agenda, and key in that is the voluntary sector. Thank you.
Sorry, Neil, I didn't see your hand there. Okay, so move to recommendations. Yeah. Okay, so approve the strategic commissioning intentions set out in Appendix 1. Everybody happy with that? Yeah. So just before we get to recommendation B, I'd like us just to have real clarity on what we're asking for the next meeting. Okay. My understanding is that although there's a 3-year piece of work to be done, you're going to be focusing on 25-26. Susan, yes?
Yeah.
Cool. You're looking to have papers out on the 5th of December for the 12th of December's that will have commissioning intentions by the intention. So last board meeting, there was about 5 different categories, each with numbers by them and how, etc. Is it your expectation to present it in that format of the commissioning intentions, the impact, the resource implications, the dates for launch, and the detail? Is that your understanding?
That's absolutely the direction of travel. My plea would be just to our colleagues and our partners to be able to help us with some of that information.
Yes.
Just finish that.
Yep.
So you're asking for a destination arrival, not a direction of travel. So we just need to be clear what that is what you want to come back to the next board, rather than an iteration. So if that is the case, we do need clear engagement with our providers and in the detail of what's in your activity. So we just need to be very explicit around that as an ask.
And Sanj, you're asking for that, aren't you? Yeah. That level of detail. Because one of the journeys I wanted to just make clear is there'll need to be an FMP before the papers go out on the 5th. So I'm just, that's why I'm trying to tease out the detail here. Mary?
I was just going to ask how people are going to be involved, because as Kate's just said, that's a tight timescale, diaries are tight. If as a board we're asking people to prioritise that, I think we need to be clear about how they're going to be engaged.
So can we come back to that this afternoon? Because Jules works for all of us, Jules Martin, who's our turnaround director. I know she's actively in our providers at the moment, working out the details of savings plans. We think this is part of the savings plan that produces better outcomes for people somewhere other than in a very expensive acute hospital. And some of the work that we're doing with CFT is around alternatives to out-of-area placement. Much better value, much better outcomes for people, much lower cost. So can we just take that offline and we'll talk about it this afternoon, but then when we come back, maybe early next week, we need to be getting coups together, Susan, to talk about how we are going to take this forward.
So I'm quite happy if everybody else is. I mentioned the 5th, which is a Thursday. Given the fact that part 1, part 2, with everyone and the public's support, I think they can go out on Friday the 6th, because I think you're available on the 6th, aren't you?
Yeah, because we're planning to have the meeting on the 6th.
That's why I'm trying to just get real clarity as to the journey. So what it means is board papers, if we're happy for this, we'll go out on the Friday the 6th after an FMP meeting on the 6th. And then we can all do due governance, challenge, scrutiny, support and whatever. And you'll take Mary's point about how we therefore later marshal the forces to get to that point.
So I think that isn't just our responsibility. So we will be making asks, and we're going to expect that everybody's in this together. So we'll all do everything we can in order to be able to get the engagement in the right places. But this is where I don't want to go back to us questioning the evidence. If people are using it nationally and internationally, I don't know why in Cornwall why we have to do it again. We just take it and apply it.
So we've agreed that. I just want to feed in with Kate's and Terry's support here. I've just talked about walking towards the December board meeting. We have a January board meeting, but the board papers would have to go out on the 2nd of January. Little thing called Christmas and New Year in the window. And actually, what's the key driver is that on the, I believe it's the 7th of January, there's the national NHSE sign-off of oversight frameworks and probably finances and everything else that goes with it. So if it's all right with everyone, I'd like to minute the fact that I'd like to take away with the chief executive and the company secretary, at very least, pushing back the January board meeting a week, and if not, changing the environment to make sure there's no point having the meeting if actually it's in advance of something really important that comes from the national team. So are you happy to go flexible? If not everyone can make it in January, I get it. But I think so long as we can actually set up a structure, by the time we get there, I think we should be, from Cornwall and Arsenal City perspective, as close as we are by December. And then really what we're sense checking is what comes out of the national thing that means we have to consider any changes. And that for me is a delta, a gap. I hope it shouldn't be too big because we're going in the direction that government wants to go anyway. Is that okay with that, Rachel, as well? Everybody happy with that? Sorry, that was a long way to get to the recommendations, wasn't it? But I think it's an important journey. So if we now move to recommendations B, we're effectively inviting healthcare services and our partners to help plan that over the journey, not just of the 16th of December summit, but based on the timelines rather than repeat it all. Are you happy to capture what I've just said? Put that in the minutes, everyone's happy, and then we can move on from there. Are you happy with that?
Perfect.
Everybody happy? Done. Thank you very much. So that's that paper. So where are we? 25 past. So I think we are going to need to run, if it's okay with everyone, to the times that are given per paper on here. That means lunch is put back. We'll start part 2 later. That's all right with everyone. Okay. We've got some pretty important stuff on here. So, Tracy, the joint forward plan.
Thank you. So just a reminder for our newer members that we have a 10-year integrated care strategy and a joint forward plan, which is effectively the delivery plan for the next 5 years. And we are required statutorily to update that and refresh it annually by the 31st of March. And that is a joint responsibility of us, RCHT and CFT. The refresh is a look back to what we've done over the last year, as well as a look forward to the refresh. We are aware that that time frame of the 31st of March is ahead of the 10-year plan being published, and therefore ideally we'd be doing it in the context of that. But we've had discussions with NHSE, and given that it's set out in as part of our legal duties, there is no leeway on that annual refresh. It will effectively, the refresh we will do in a as agile a way as we can. We will ensure that it is very much linked in to the work we're doing on our multi-year commissioning intentions, reflecting the engagement we've already done, but also the engagement that's still to come around the 10-year plan, and our path to recovery of our key performance standards, plus maintaining financial stability. So there'll be a key link to the medium-term financial plan. There is a specific ask of our particular joint forward plan. So it's part of our ICB annual assessment. And last year and the year before, we were asked to ensure that we had more specific metrics that we would be measuring in terms of that 5-year delivery plan. So we will, so the modelling we're doing around the commissioning intentions, we're looking further than we might otherwise do over a 5-year period rather than just 1 or 2, in order that we're doing this work once to inform that process. So just to reassure everyone that we are building on the work we're already doing, making sure it's aligned rather than looking at this as a separate piece of work. We're utilising the engagement we're already doing, and we're refreshing the outcomes expected from our commissioning intentions work. There are 2 amendments proposed to reflect the work we're doing in terms of objectives. So we are suggesting under transforming care, bearing in mind this goes back to our integrated care strategy, we had 3 overall aims: operational recovery, improving value and transforming care. So we're formalising channel shift under our transforming care as a new strategic objective consistent with the work we've already started. And we are proposing we add a new objective of tackling climate change and moving towards net zero emissions, recognising we are expecting a new guidance on a refresh of the green plan, which we're intending to do by the end of the year, and recognising the challenges to delivering on those commitments. We are required to consult with both the Health and Wellbeing Board and our Integrated Care Partnership before we take the plan to the boards of RCHT and CFT, and then it has to come back here for sign-off in March. So we've had a look at the meetings of RCHT and CFT. CFT's is the day before, so we'll make sure we've engaged in a way where if there's anything fundamental, we'll have dealt with that before it goes to the board, and our ICB meetings on the 13th of March. The dates for the ICP and the Health and Wellbeing Board, there's nothing in the diary around that February date yet, so we'll need to liaise both with Rachel and council colleagues and with Terry about ensuring we've got those lined up in a way which ensures all of that works smoothly. So it's really here today just to say we've started the refresh work, we're aligning it with everything we're doing, and we've got a plan to bring it back to the March meeting.
Any comments?
Yeah, grateful for that. Can I just check, Tracy, we've got engagement from the relevant providers, I think as you said, it's CFT and RCHT right from the very start, so that we're jointly developing the paper. If we had, we perhaps could have taken this paper to RCHT's and CFT's board as well, so that's
one of the recommendations that we ask our provider boards to consider the approach and provide early feedback to shape the refresh.
And it's just to check, and this is a jointly agreed paper that's come to this board, jointly agreed with CFT and RCHT already?
In terms of the paper, to be fair, it probably isn't. So that's why we're asking for your formal feedback on this paper, and we'll make any amendments.
We've got time till March to do this.
Yeah, good point. I take it on board.
Because one of the points looking around, everybody else wants to make an observation. Tracy, one of the things that, because this was written originally a while ago, and it's a refresh.
Yes.
But we've had a change of government since then, and even when we stepped out again, we heard the Secretary of State talk about their 3 big principles of analog to digital, hospital to community and sickness to prevention, should we not in some way weave that as a messaging? I know I'm not looking to change it. I'm just trying to say, if that's the Secretary of State's view.
Correct. So that's the proposal that we add that in as a channel shift and those 3 elements as part of our transforming care.
So the lozenges become those 3.
Yeah.
On the right-hand side, they become the 3 thing.
Yeah.
Perfect. Excellent. Everybody happy? So we'll move to the recommendations. Note the statutory requirements to refresh. Thank you for that. Endorse the approach set out in the paper and the additions that we've spoken about, and you'll add the Secretary of State's top 3 items and take
and net zero is zero.
and net zero. Yes, thank you very much in that. And we'll take on what you had anyway as a proposal, but noting Steve's point about asking provider boards to consider the approach, give us early feedback to refresh requirements. I think we should say here, with a view to concluding in March.
Correct.
Happy with that, everyone?
I'm assuming, I mean, that it's not a radical rewrite, it's just a review, isn't it? So essentially you have us already as a system signed off a plan. It's just noting that it's refining, as you say, but I'm not hearing radical change.
No.
Great.
Other than the
advice we've
cosmetic
been given,
bits
really,
of
given what's coming.
presentation, please the bodies that need to be pleased as well.
Indeed, yes.
Okay, very good. Thank you very much. So we'll move on from the Joint Forward plan. So, having spoken to the sponsor of the next 2 items, which is Chris, which is transforming primary care strategy and recovering of access to general practice, we're going to take the topic in the round as a discussion, and then once we finish that, we're going to go back to the separate papers recommendations and deal with the 2 recommendations in 2 separate ways, if you see what I'm trying to get at. So please, if you had anything you wanted to say on the second paper, I'm going to try and capture, with Chris, everybody's support now, both papers in the round, led by Chris, and you are inviting some colleagues to present, is that correct?
Yeah, so Stuart will talk specifically to the work that the GP Collaborative did for the GP part. Yeah.
Lovely. So off you go, Chris, we're in your hands.
Yeah, thank you, Chair. So yes, I'll take the 2 papers as read and together. And so I'm just going to highlight the key points around the recovering access to general practice. So just for clarity, the Department of Health and Social Care in May 23 came up with a delivery plan with the key aims of what's called addressing the 8 a.m. rush. And everyone's very familiar with the days of patients queuing to get into the GP surgery, never mind queuing on the phone. And I recall often teaching medical students the person at the front of the queue is the person with renal colic because they've been there waiting the longest to get in. But so we want to avoid that. And the other key issue is knowing, if you do talk to your GP practice, you know on the day exactly what's going to happen. So when your appointment is and who's going to see you. So we've been asked to bring just an update on where we are with recovering access. So this is what that paper sets out. And if I just point out, in terms of the current position, there has been an improvement of 4% on getting an appointment within 14 days. And actually, GP-wise, compared to the national average, the appointments per 1,000 of our population is 604 against 528 nationally. We do, however, see lower face-to-face GP appointments, but I would actually say that's a positive because we're using other parts of our GP workforce and what's called the R's roles, and also making better use of telephone appointments. So that's the key issue, and then that's on the challenges. Obviously, as Rachel can confirm that that our population in the last 20 years, the over 65 age group's gone up by 50%, and so there's a lot more people who've got more than 1 or 2 long-term conditions, and of course deprivation has actually got worse, and that affects health spans. So there's a lot more work for our GP colleagues to do. And also noting during this time, they're in current collective action as well. So that segues into the primary care strategy, which of course is not just about general practice, it's dentistry, community pharmacy, optometry. And, right now we have 72 dental contracts with the NHS, 48 optometrists, 92 community pharmacies and 55 general practices. They're all independent providers. And as Lord Darcy pointed out, they're probably getting the percentage of funding compared to our acute sector has actually gone down in the last years, and that's part of the Darcy review highlighted that needs to be reconsidered. And in the last 12 months, our GPs in Cornwall and the Isles of Scillies had 4,435,000 appointments, which is in essence saying that in terms of face-to-face appointment and activity, that's 3.7 times more activity compared to the acute provider for 5 times less of the funding. We've mentioned, I think already, Chris Whitty's report around that health in an ageing society. So the challenges of coastal, rural, deprived populations just adds to the work that needs to be done in primary care. So it's with that context that the paper sets out the Commission's intentions, and as we've already heard, very core to that is around developing our already established 16 integrated neighbourhood teams, which are already very much community facing with the voluntary sector, to make sure they start facing more of the secondary care facing. And because again, the evidence, as Kate has already said, is quite clear that if you do that, patients get a better service, the quality goes up, your workforce is happier, and there's less pressure on the acute system. So the Commission intentions are set out on page 7 and 8 in the, if you look at it through admin control. I will just flag, obviously, it's not just about general practice. The same priorities are being given to community pharmacy and dentistry, who've got the same workforce issues and challenges with the population. And I just want to acknowledge the Health Watch report around dentistry, which I think sets it out quite clearly. We've got a lot of work to do. And some of the actions that are currently underway to address the issues flagged in the Health Watch report for dentistry are set out in the paper on page 30 under admin control about what's happening there in dentistry. But as I just want to emphasise, I think we've got a lot more work to do there. As I said, that's a whistle-stop tour, and I think, Stuart, you're going to talk about the specific work, acknowledging that there's been a lot of collaboration in coming together with this strategy. So as chair of the GP Collaborative, you've pulled together the GP part of the strategy. So I'll hand over to Stuart, if that's okay.
Thank you, Chris. So for those who don't know me, I'm Stuart Smith. I'm a GP partner here in St Austell, where I still work 2 clinical days.
Stuart, so bear with me. Do we have a technical problem? Sorry, Stuart.
Broke the internet.
The Wi-Fi problem.
The Wi-Fi's not brilliant, is it?
One for me as well.
See exactly when.
I don't remember. My phone just kept cutting out this morning. It's dropped. On completely, isn't it?
Pause for a moment.
It's just it's like a power cut or something, isn't it? I should see just going.
Mostly my son. And a couple of other people.
Yeah, Chris has covered it anyway, so we're...
Find you in all meetings in the future.
I know, yeah, you're the same look.
Yeah, but as you go along, it's just like, yeah, I know.
Yeah, done that.
Really got
exactly.
So,
when lunch arrives,
yeah.
we might actually try things forward.
Okay, yeah, so lunch should be. Well,
About 20 minutes. So he's out there now.
You have literally broken the internet, Stuart, with the vast brain power has just gone.
Right.
It's like a mic.
Are you happy for break lunch now?
There we go.
Colleagues.
Well,
can I make a suggestion? We have half an hour for lunch. The best laid plans of mice and men. We've had the Secretary of State and the Chief Executive call us out today. We've got Wi-Fi issues technically going ahead. I don't think we can really continue in all good faith. You're back in. was about to have lunch. Sorry, I'm such a tease. I'm so sorry. So, can I just before we interrupt Stuart for a second time, can I just check, Peter and colleagues, are we live? Yeah. Can you hear us? You can hear us. Are you able? You've got a presentation, haven't you? You're going to be doing, Stuart.
No. I'm just going to talk.
There's a presentation. Okay, away you go.
Okay. You were nearly saved from this, and we were nearly ready for lunch. But okay, I'll start again. I'm Stuart. I'm a GP here in St Austell. I work 2 clinical days a week, and I'm also the clinical director for our PCN. I'm a clinical director for one of the ICAs, and I'm here in my capacity as the chair of the GP Collaborative Board. Just important to recognise what the GP Collaborative Board is. It is a collaboration between our 15 PCN clinical directors, our LMC, and that's crucial, and that's actually quite unique compared to other provider collaboratives, and our CIC. What I think we were brought together over 12 months ago now, because as you will know, and as Chris has just laid out, in the context of collective action and a workload and indeed financial challenge, as well as the ageing population and no real increase in GP numbers since the mid-1990s, whilst we were acknowledging that national policy needs to change, we felt that it was important to start shaping our own destiny and aiming for a modern, resilient general practice within Cornwall. Now, despite those challenges, you've heard that actually Cornish general practice in and out of ours does perform very, very well against national standards, acknowledging that there is, of course, variability and increasing fragility. So the Collaborative Board set about a real bottom-up plan to develop local solutions and try and provide a more modern and resilient general practice, but crucially also working with our primary care team to make sure that what we were doing was in line with our ICB agendas and, of course, national policy. And what we think is that we've brought about a general practice plan that is, a collaborative board plan that hopefully underpins the primary care plan, at least the general practice part of it, that provides the foundation for more modern, resilient general practice, but also the foundation for channel shift. And within that are 5 task and finish groups that you can see yourself again locally led by our GP leaders, and hopefully supported by the grassroots of general practice as well through regular communication, and again crucial to that our LMC's involvement within that. Those 5 task and finish groups include the primary care hubs, AI augmented patient segmentation to improve continuity for people who need it most, a medium to long-term goal of safer workload and an early escalation of practices in challenging situations, concentrating on supporting the partnership model, and where that isn't working, finding local alternatives to that. And then crucially, and I think this is the most pertinent bit to what we're discussing today, trying to develop a more proactive frailty model and move away from our reactive response to frailty, therefore supporting our urgent and community care, emergency care. Thank you. I think I got stuck in the same point as you, Susan. Urgent and emergency care system, and actually acknowledging the importance of SDEX and CATUs. Actually, our goal should be to keep these people at home before they reach even that better care option. So hopefully you can be assured that the primary care paper is underpinned by general practice supporting it and having co-designed it. And I think that is important to celebrate that. That is a unique across ICSs as far as I'm aware. And there's been some coverage of that in the HSJ last week because of that. I encourage you to reach out to other ICSs and see what their experience is in terms of collaboration with general practice, because often you'll find it's very, very fragmented and some difficult relationships. So the paper sets out, as I said, what we think is the bedrock for modern, resilient and high quality general practice, acknowledging that there's some national policy that needs to augment that, and indeed the foundations for channel shift. There's some significant workforce issues that need to underpin that. And again, we're working with our CIC and our excellent training hub to underpin that. And then, of course, the elephant in the room, which is if we really are going to, even remain the status quo in terms of quality, but really augment what we're doing with integrated neighbourhood teams, there is significant investment in estates. And we're talking about primary care and integrated neighbourhood team estates here that need investing in. So hopefully that gives you a bit of a background of how we've co-designed this paper with our primary care team. And we should also celebrate Chris's team. I think Paula might be online in terms of that collaborative relationship that we have in Cornwall. And I'm very happy to take any comments or questions on my part in that.
Thank you. I'd like to bring in a couple of colleagues first, if I may. So Emma, would you be kind enough to give us your thoughts on that?
Thanks, Chair. I think there is little to add to what Stuart has said in terms of the really healthy way in which this has been brought to bear. I think all three of the organisations involved in the collaborative board have got a lens through which they look at these things to try and get an holistic whole, and that's where we are, I think, really. I mean, there are challenges that are sort of sector specific, but really have enjoyed that participation and feel really proud that we've sort of got to this point, because all of these things, whether they're the difficulties with funding, with collective action, whatever they may be, are all there ultimately so that we can find some solutions, not to simply lay bare the issues and leave no solutions to go with those. So really welcome it and very grateful to Stuart for that kind of, it takes a lot to get all the GPs in a room to agree together. So really that direction's something very much that's come under Stuart's chairmanship. So thank you for that.
Just before I move it round, something that Kate said earlier on, we do a lot of things in Cornwall and the Isles of Scilly and we don't shine our lights on it. And over the last couple of years, personally, just from my perspective, I've seen a huge collaboration that's going on at General Practice. I wanted to reach out and say thank you to you personally, thank you to the collaborative group, and I think the engagement structurally now in terms of how we go about making real change will be much faster and more scalable by that collaboration actually taking place. So, Smitesh, can I bring you in? You are our statutory partner on the board. What's your
Yeah, no, again, I think Stuart has said the majority of what needs to be said from this perspective. I think the model that's being developed there is a great foundation to develop the integrated neighbourhood team, kind of working and enable that that channel shift that is required to essentially bring care from the hospital out into the community closer to home, which is a real key part of what patients want and what we need to do to help our system be more sustainable. I very much support it.
So let's move on to other people who would like to raise their hand. So Patrick.
Yeah, thanks. I just wanted to draw attention to page 77 in the pack. Is a really good model of the future challenge around this strategy. It shows the workforce position based on population size. And what, if I'm reading that correctly, that shows that even if we're able to increase our GP population in proportion to population size, there's a really salutary statistic there around the number of GPs per 10,000 people over 65 would fall in proportion. I'm only highlighting it because it shows the longer term challenge that the collaborative approach we're taking needs to respond to, but it also shines a light on the work that the training hub do to support, because that statistic is from their work. So yeah, it's really helpful.
Martin?
Just 18 questions on the whole paper or just the GP bit?
Whole paper?
Yeah, mine was on dentistry really, which, I know this is a sort of strategy rather than a delivery plan, but, just looking at the, unvalidated numbers of 100,000 people waiting for an NHS dentist, what I can't glean from the pack really is how much difference is this strategy going to make? If I'm an individual in the street, as it were, are we going to next year, the year after, by 3 years' time, see a real significant difference in people's access to NHS dentistry, or are we really just, trying to tweak around the edges and it won't really make that much difference, or are we somewhere in the middle? I just can't tell from the pack.
Let's ask Kate to answer that one, please.
So I think it's difficult to answer that question at the moment. So one of the things we do know is there's loads of discussions going on centrally around how they're going to look at the commercial contract for dentistry. We haven't got any feedback from that yet, but consistently dentists are saying if you want to have more dentistry, you need to address that. We have interviewed for our dental advisor to the ICB, and I'm not sure we've made a decision about who we're going to appoint. But Paula, who's online, and Kirsty, I would like to speak to them quite quickly, because we need to get some really good dental advice into the board. We've benefited hugely from great GP advice into the board. So we need to make sure we make that happen.
Yeah, I think earlier in the year, we said how terrible it was that this is one area where we actually have money, but we're not managing to spend it.
And it's a real inequalities in health issue.
Inspiration to try and spend as much as possible as the UDAs, didn't we?
I might ask Stephen, Emma, were your questions on dentistry? No, I'm going to bring in Debbie because I bet yours is.
It is.
Go for it.
Thank you, Chair. I'd like to start by thanking Chris for acknowledging the Health Watch Cornwall report that's recently been published and highlighting the recommendations. I wonder if this is a good time, if I could ask, when would we be seeing the dental strategy? When is that going to be on the agenda? Because obviously, we have to keep this topic at the forefront.
More than just a strategy. I mean, I do really mean it.
So I think this is the prime. Sorry, Chair. Yeah.
Sorry.
So I think this is the primary care strategy, of which the dental strategy at a high level is set out. I think obviously what we need to bring back is, it links back to Martin's question, is the detail of the impact of the actions that are doing, which is around, I can list all of the actions, but what we want to see is, and therefore what's the impact, which is around getting dentistry to be more stable, so less dentists leave the NHS. We still need to find the workforce, additional workforce. Then we need to uplift their UDA, that's how they get paid. This is part of their national contract. But there's things that we can do at a local level, which is around what's called rebasing contracts. So that gives them, instead of clawing back money for unspent UDAs, that they're in a more stable position. So there's lots of things we'll bring back in detail and show you.
I'm trying to answer your question in terms of when, though. So Kate, could you answer the when question as well on dentistry?
So I think for the 1st of April, we need to have a cost of delivery plan for next year. And even if part of that cost of delivery plan, we've still got gaps, at least we can then be clear what the gap is and what we're going to do about it. Because at the moment, we've just got a really long list of unfathomable problems. So I think for the April board, we should endeavour to bring that back.
You mean the March board for April?
No, I think the April board. Yeah.
Okay, that's fine. So April board. Debbie, is that okay?
Yes.
Lovely. Yes. Good answer. Thank you. Steve. Sorry. Just trying to keep a bit of levity in the room. Keep us awake.
Absolutely.
Steve.
I think it's a great paper. Both papers really clear, really helpful. So just want to acknowledge that. The question I've got builds on Patrick's question, and it's about future GP workforce. So if I've understood it, I think the last Royal College survey was identifying something like 39% of GPs nationally were saying they were seriously thinking about leaving the profession in the next 5 years. And that, alongside what I understand to be the age profile of GPs nationally, is suggesting quite a higher rate of retirement as compared to new colleagues coming into the profession. So I just wondered to what extent this strategy has kind of addressed or can address that risk of a potential quite significant change. I know there's figures are national, I've just not cited on what that looks like within Cornwall and the Isles of Scilly.
So, I mean, that's a really important issue to raise. We had a full day at the Collaborative Board on Tuesday, doing some detail work with NHSE on something called optioneering, which is the first time it's been done in primary care. So again, in Cornwall, hopefully trying to lead the way to face up to those issues, and a prediction of by 2037, us being short of 120 GPs in the county, and already thinking about how do we look at bringing more GPs in, training more GPs, and crucially, what is the model of care that because actually the way that it takes 4 years to train a GP. So even if we make a policy change now, it's too late. So crucially, how do we change our model of care? Really, I think to work in those integrated neighbourhood teams and bring care from the hospital and closer to home, Steve. So two things: we need more GPs, and we're on the case and looking into that in Cornwall. And we need a different model of care. And actually, again, one of the blockers for training more GPs is a lack of estates. So even last year, we had to find very creative solutions to 5 GP placements in this county because the estates didn't account. So that's a critical blocker.
Okay, so the order we're going to go with, because we've got a few people, and then we're going to draw a veil over this and move to the recommendation. So we're going to go, Kate, you wanted to answer this, and then we're going to go Emma, Debbie on the screen, and Neil, and then we're going to move to recommendations. So, Kate.
It was just for the discussion that we had with Richard Muddings around a decision being made by our region to focus more on bringing more GPs into general practice who also have a public health view of the world. I grew up with that model in the East Midlands. I think it is amazing. So I really welcome that as a step forward. Estate is the limiting fact for practices to take on trainees. So when we are starting to look at our capital allocations next year, we need to make sure that we've got general practice within our planning vistas.
Okay, thank you. Emma?
You both. I think that was a really welcome strategy, and particularly the explicit acknowledgement that we need to invest more in particular areas to tackle health inequalities. I think that's really important. One of the reflections I just wanted to make was around the links to the voluntary sector, particularly local community hubs. So we've already got some really exciting examples of where community hubs are co-locating and already hosting primary care, traditionally primary care roles, and seeing some significant impacts actually on patient care as a result of that. So I think in terms of the estates discussion, we do need to be thinking more broadly from primary care surgeries and practices to encompassing things like community spaces, and not just from a kind of theoretical co-location, but also from an investment perspective for the future, where we're thinking about those community hubs as part of our wider system infrastructure.
Very good, thank you. So we're going to go Debbie on the screen. Can't hear you, Debbie.
Oh no.
Hang on, try again, Debbie. We're trying to sort it at this end. Okay.
Just further Emma's point on that, notice how we said integrated neighbourhood team estates, not just general practice estates. And I mean, it's not only from a business and a financial point of view that's what I mean. Actually, therapeutically, it's much better to have your mental health addressed in a nice community environment than it is in a clinical space. So
outdoors,
yes, or indeed outdoors. Absolutely.
I know, Chris, you want to say something, but Debbie on the screen, can you chat again to us?
Yeah, I'm hoping you can hear me now.
Yes. Go for it, Debbie. Go, Debbie.
Yeah, okay, thank you. Well, and I came just in on hearing mental health, so I hope I'm not repeating the point that's already been made. But I just wanted to say that I really welcomed the increase in budget in the commissioning intentions for additional roles in primary care. We've already seen the impact that the ARS workers, the mental health practitioners in particular, and the health and wellbeing workers have made. So I welcome that. But I just wondered, from a strategic perspective, how do we ensure that we're maximising the value in a consistent way across all of the 16 integrated neighbourhood teams?
Who wants to capture that? Do you want to capture that, or Chris, or Susan?
Yeah. So yeah, I agree. I mean, I think first and foremost, I think it's welcome that in the using INTs, mental health's already aligned to those 16 INTs, so they're already one step on the ladder. But in terms of the impact, I think this is where the population health dashboard, our health inequalities dashboard, comes into play, which we can show in relation to the 16 integrated neighbourhood teams. So the impact that by working as a team the impact it has on our acute sector in terms of reduced referrals, the impact it has on unplanned admissions, and I think that becomes an important part to understand how the workforce works together. As I said, because there's plenty of evidence to say that this has a positive impact from workforce. So I would like to use the INT as that platform for how we look at the impact from a population health point of view.
Just before I bring in Kate and Neil, you had your hand in there. Is that the point you wanted to make, or did you want to come back in a second?
It was very quickly about a stage, just pointing out the Helston project that's already underway, that Claire Fuller came and visited, as an example of how we repurpose a supermarket, not just for general practice, but as a community hub. And I think these are the examples, Emma, that you've raised that we're going to have to find, because Steve's point around the tension of making sure the workforce, both in secondary care and primary care, because they're going to have to change.
I see Stuart nodding, so that's in general agreement by the sound of it. Emma, thank you. So quickly, Kate, and then we're going to go to Neil.
So I just wanted to pick up Debbie's question around strategic workforce. So one of the things we do now is the R's roles are great. We spend all our money on them and they're in general practice, but they're a cost pressure because when general practice gets its uplift on a 3-yearly basis as part of the contract, it doesn't build in the agenda for change uplifts that the R's workers get. So I think there is a strategic question around the employment model that makes that guaranteed, and then the delivery point through which the roles potentially are delivered, because then that's baked into our settlements and allocations in the county. So I think it might be just something that we might need to look at. And as the INTs become live, and so sexual health services where I live is shared across INT boundaries. So what are the services that would be across more than one PCN, and how would we start aggregating those up? So I think it's just a question for the future that we haven't got an answer to yet, but we might need to start looking at as the INT model rolls out.
Thank you. Neil?
Thank you, Chair. It's just to very much welcome the proactive approach that the Collaborative Board and LMC and other partners have taken on this, and I hope that other partners can see this as a potentially solid foundation on which to build spreading services and workforce. And Stuart, some years ago, we got worried that those of us who are a bit old and grey who wanted to take these types of new model of care were not actually getting it right for the younger GPs. So we actually had a forum of young GPs at that time who were all solidly behind this new way of working in integrated team type working. Do you believe, Stuart, that this might be a way, if you're taking a lead on this in Cornwall, to actually attract more GPs to come and work in the county?
Well, that's the aim. I'm just reflecting that I've now become an old grey suit. So, yeah, of course, that's the aim. And I was just jotting down, actually, one of the discussions we had at the workforce meeting this week was that it's just absolutely crucial to start engaging with young GPs. And it is a changing demographic. It's a lot more international graduates. And that they want, along with in a lot of other areas, different things out of the profession. So, yeah, we've got great relationships with our VTS scheme, and it needs to start there in the co-design process. Thanks for that reality check.
You're wrong. I don't know what that makes me. Right. Okay, colleagues. Firstly, thank you to you personally, Stuart, and to the whole GP Collaborative. Would you pass on our thanks to the whole Collaborative Board? Thank you to you and Emma and all the colleagues involved in this. And I know that's a GP Collaborative group, but of course this is a primary care paper. So we've noted the dentistry issue, but we haven't mentioned pharmacy. So given the news today and that kind of thing, can I just ask, when does pharmacy actually get writ large into the primary care paper?
So you're right. I think it still needs further work with our community pharmacy colleagues. Yeah,
it'll come back in December. Yeah. Okay. So can I just be really explicit so we're clear on what's coming back in December? We're actually going to have a commissioning intentions paper that we spoke about earlier on that will come back with what we're going to do on general practice, what we're going to do on dentistry, albeit flagging that it's going to come back in April. Yeah. Yeah. Is the money ring fenced for that? So it's not an issue in the
So we know that this Service Development Fund for next year will not have all ring fences that are currently in place maintained,
Okay, cool.
but we think dentistry and definitely mental health will be.
So dentistry might have a bit longer burn to get to, but you will come back with granularity on where we're going on commissioning intentions with pharmacy for 25-26. Yes? If we could note that, I'd be very grateful. Thank you. So we'll move to the recommendations. And as I said before, we're now going to go back to the 2 papers and go through each one in a structured kind of way. So we go to the primary care strategy paper. The board is asked to approve the primary care strategy and collaborative board's plan for general practice, provided in the appendices. Are we happy?
Yes.
More than happy. We can actually note, I suspect.
Right.
Thank you very much for that. Endorse the commissioning intentions for primary care. Are we happy with that?
Yeah.
Thank you. So if we now move to the next paper, which is the Recovering Access to General Practice paper, and go to its recommendations. The board is asked to take assurance from the update of the progress made against the National Delivery Plan and checklist. Are you feeling assured? Happy to take that recommendation?
Yeah.
Yeah? Yep, we'll take that done. Fine, thank you very much. I don't normally take silence as support, but I think I will.
Everybody's looking around at each other.
That's it.
Jack, could I just ask us to thank Debbie and her team at Healthwatch for the dentistry report, because it's a really, really helpful report.
Absolutely.
And I think it just keeps very much centre in our minds the impact it has on individuals as well as the challenges we face. And some of those structural things that get in the way of doing us the right thing, we should be feeding back as part of our response to the 10-year plan.
And I agree with that. I hope you feel managed to make sure that you had your moment on the dentistry element as we went through that.
Thank
and if
you.
we can structure you and Healthwatch to make sure that as we go through future boards, that we find some structured way of feeding that. And we've talked before about how we do that, but if we can talk again, that would be really great.
Can I suggest when we've got our dental advisor then meet with you, Debbie,
Yeah.
and that part of our plan that will come through the dentistry part of primary care is feeding in what people are saying about their experience of service. So we do the same as we do with everything else. The people who experience it get to say what they'd like to see changed.
Okay.
Yeah.
Very good. Thank you very much. So let's move on to the next item. So we're running about 10 minutes late. Simon, SIP and productivity update.
Thank you, Chair. I will be very brief and take it that people have read the report. So it highlights favourably that we are over plan now in terms of CIP delivery. There have been significant improvements, in particular RCHT, over the last couple of months, which then supports an overall position for the system, which has delivered the in-month 6 position as a net position for our system. And we're now on track with an agreed revised financial trajectory with NHSEI to deliver our plan for the rest of this financial year. So there's the positives in that. I will say against that, we're still describing a medium risk as a system because there are still significant challenges to work through month on month. But in terms of CIP delivery, it's positive currently, still a lot to do. And the other point I want to make, particularly in relation to 25/6, is I think we're all agreeing there's a huge emphasis on the recurrency of cost improvement. And we're looking to do everything we can during this year to reduce the burden on our resources in 25/6 by maximising the percentage of cost improvement that's delivered. So in our current MTFP, or the last one that was drafted and shared with colleagues, there was a £59 million exit run rate. And the more we can do now to increase CIP and reduce that pressure, that makes next year that little bit easier, which I think is our focus. I will mention productivity. In the report, there is an improvement. It's 13.5% implied productivity for RCHT because we report against the acute sector at the moment only. And that shows an improvement against previously reported about 18%. So there have been some good movements in the right direction. I will say that there are some bits of national audit work going on and local audit work that may affect that position, but we need to work through that and bring that through in month 7. But it is a positive step in terms of reported productivity for RCHT and the work that's been done for there. I'm going to leave it at that, John, but happy to take questions.
Yeah.
The first comment is we need to, we're always quick to say when things aren't going well, so we just have to notice the work that RCHT have done and the productivity increases that they've made over the last year. Great to see and great for our residents. In terms of exit run rate, we were advised by Richard Medding when he was with us, don't wait till April. If you've got anything you can do between now and then, you need to start bringing it forward, because we'll feel like we fall off a cliff if we don't. So services such as frailty in the community, end of life, and the use of alternatives to an acute front door, we need to be bringing forward now for impact during the winter. So when we start talking through the service models that we're looking at in part 2, I think we should be thinking not to defer, but to bring forward so that we get a full year's benefit and winter benefit too.
Saj, is there anything you'd like to add?
Yeah, only to flag that I think the recurrent SIP delivery is significantly below. So it's really well done on getting us ahead of overall delivery, but it's the
recurrent
uneven balance between recurrent and non-recurrent that we still need to keep an eye on. And with productivity, I think, you know, the challenge remains that we don't have a complete picture because we only have data on the acute side. So we don't know what we don't know. So there is a gap and a lack of assurance I can give you on productivity of the system as a whole.
You know, Simon and then Steve.
Thank you. I just wanted to take the opportunity to enjoy the moment of our H2 meeting where we were super congratulated
Indeed, yeah.
as a system to be on track this year in terms of and being, I think, one of 10 ICBs in the country that continue to report delivery against a break-even plan and to be in year on plan, on a revised plan. So
this will be our 4th year.
This will be our 4th year.
The comment that was made is we were in a special club to start off with. We were one of 10 who had declared an intention to break even. We're in an even smaller club as we go through the year and we're hitting the plan that we set for ourselves. So I just think a moment to congratulate loads of hard work.
Absolutely.
So thank you to everybody.
Thank you, everyone. Hear, hear. Steve.
Yeah, and I support the comments both Simon and Kate have made. I just wanted to raise a note of caution about the productivity information. That the productivity report in month 4 is an extraordinary productivity improvement, and if that was correct, we would have achieved, from an RCHT perspective, almost the full year plan in the first 4 months. I think part of what we're saying is because it only compares the first 4 months this year with the first 4 months of last year, it's a very short snapshot, and I think
last year, 1920.
Well, it compares both last year and the 1920, but it just compares the first 4 months. And what we found in previous years is the information becomes more accurate by the time you get to the month 6 position. I think what we'll see in month 5 is a worsening of the productivity position, but still an improvement at the start of the year. So I just wanted to flag that when we see that will still be on plan. But what we're seeing here is something which is significantly ahead of plan, and I think it's because it only compares the first 3 or 4 months of the financial year.
A couple of observations I'd like to make. Does anybody else wants to say anything? No. Martin, you are a non-exec in other places in the NHS. Am I right in saying that they also take the national stats and then do a little bit of a projection? Because I'd written down here. This is July. Is that right? Like month 4. That right?
Yes, sorry.
Yeah. It's month 4. So bearing in mind, where are we? November, which is quite a journey in there. We must have an internal guess, I would have thought. Do you do that elsewhere?
We do, and it can be done if you factor in the savings programs that are going to come in the second half of the year, the activity that we plan for in the second half of the year. Put those two together in the form.
Is that something you'd support?
We have it already.
Oh, would you be happy sharing it?
We have already.
Oh, you have
apologies, apologies, John, but we do. It's validated and checked and responded back to us from NHS England. So we do have a month by month trajectory, which is why I was raising the month 4 position is significantly better, and I think the month 5 will bring us to track.
As you know, RCHT and CFT are invited to the FMP committees. I think this is the kind of thing, Sanj, where if you wouldn't mind actually thinking then about how in FMP you get the actual and national and then best guest estimate comes through, because I think when we see this, we ought to capture that as a board. We're always going to be running 3 or 4 months behind if we're not careful. That makes sense, Mary?
Yeah, I'm just a bit puzzled because I thought we did send it, Steve.
Well, yes, I think that the ICB team do have sight of our trajectory and have sight of the actuals against that trajectory.
Just pick it up, if that's all right.
I think just to, because we definitely have, it just missed the timeline for these, and it missed the timeline for FPCC.
We could just capture both for FMP committees and the board going forward.
We should have it for the next FPCC.
That's my point.
Yeah,
And then
okay.
ongoing, because I think that's an
Great.
important subtlety. Because this one, I won't say it's my favourite numbers, but it's my favourite slide. Because even I can understand this one. This is if you look back, I don't want to miss this point. If you look back a year ago, even this is a dramatic shift forward. It's still down on 1920, but it is a significant step forward. So I thought we ought to just recognise that. Okay, so happy for us to move to recommendations on that.
Yes, the recommendation is just to
take assurance.
Take assurance.
Is everybody happy to take assurance?
Yeah.
That we're going in the right direction? Yeah. Lovely. Thank you very much, everyone. So that's that element of it. Where are we? 15:15, so 10 minutes behind. Forward plan. Now, the forward plan, I think if we look at the forward plan over the next couple of months, if we take therefore December and January, I think we've talked about in some ways, I think we need to have more time to discuss the bigger stuff in terms of commissioning intentions, which is right with you, Kate, next month and everybody. So we often get crowded out. So I want to try and create more time for the really big stuff. And then we're going to talk about what we're going to do in a single agenda item for the January one. So with your support, I think we've got to try and just focus on the next 2 months to actually get us up and do some of the radical lift and shift kind of stuff. Are you happy to go down that direction, travel in terms of forward plan? You happy with that?
Yeah.
So we'll leave that for you to work with me and the colleagues on putting that together. So that's the forward plan. Anything else on forward plan? No? So let's, I just captured that. So when we stepped out, both Steve, of course, and Debbie stepped out with us. I noted, Steve, that you gave an element of an update of your partner report. Is there anything you wanted to add? Because I didn't want to shortchange you in terms of provide a partner update to the board. Are you happy with where you got to?
I think I've covered the key aspects at a couple of points.
That's fine. Thank you. And Debbie, I wanted to give you just the opportunity. Is there anything you wanted to say from your update?
Well, we hear a lot about pressures in mental health services and demand and capacity mismatches and outcomes that we know we need to improve. So I used the partner member update report this time to focus on the CFT early intervention and psychosis service. And this is crudely described on occasions by our clinicians as being similar to cancer services insofar as it runs with a 2-week wait for a first presentation or a query presentation, and for our EIP service to now be one of only 2 services in the region rated as top performing, I think is something that we would like to celebrate. So I'm bringing this report here today by way of celebration to the hard work of those colleagues and the difference that they're making to some of our sickest patients.
And that's an excellent way to end this morning's session, because if we think about it, we're celebrating that. We were celebrating earlier on some of the work and development of the GP Collaborative and the involvement in there. You were talking about the award that we won as a partnership group where productivity is improving. We're going in the right direction, everyone. Sometimes it might not feel like it, but we are going in the right direction together. So thank you for that. Okay, item 14. Are there any questions from the members of the public relating to the agenda? I'll pause for a second. Any hands going up? Nope. Are you happy for me to close the meeting?
I am indeed.
Okay, so I'm going to formally close the meeting now. It's 20 past. We were going to have half an hour. I'll catch up later on this. So let's take until 10 to 2. If we can start sharp at 10 to 2 in part 2, I'll be very grateful. Thank you very much, everyone. Enjoy lunch.
Thank you.